passed away this week that was instrumental behind the scenes to establish the Texas Child Mental Health Care Consortium, a man named Tom Luce. And many of you may not know how helpful he was at the very beginning to get this up and on its feet. But I've asked Andy Keller since he's worked with him in a variety of ways, just to take a moment to just to honor him. And we can talk a little bit about how he really got us to where we are today. And so, Andy, do you want to say a few words?
Yeah, thanks, David, and thanks for taking time about this. Tom was really a pretty singular individual, and for better or for worse, none of you would know me if it wasn't for Tom Luce, because Tom really is the reason that the Meadows Institute started. So he was our founding CEO and president, and I was his policy advisor back in 2014 when we started. And that same session, Tom was actually named to the Sunset Commission that was at that time reviewing HHSC, which they now are again for the first time since 2014. And when he was named to the commission by Speaker Strauss, Tom said, "Hey, I just started running this Mental Health Policy Institute. Is that a conflict?" And Speaker Strauss said, "Well, are you going to charge me any money?" And he said, "No, sir." He said, "Well, sounds like free help to me." So that's kind of how we've positioned ourselves in the state since, free help for Texans who want to change mental health policy. And so Tom really is the reason we got going, and Tom is the reason why we were trusted with being able to be in various discussions. And so one of Tom's most important relationships was with Senator Nelson, Jane Nelson, who they went way back together. In fact, I think Senator Nelson may have been his, maybe she may have been like, oh no, she was very involved in his governor's campaign. She kind of helped him involved when Tom ran for governor in 1990. So they went way back. So, as we looked in 2019 about ways to help children's mental health care, and the consortium at that point was didn't exist, but the chairs of psychiatry meeting did. David, had the idea along with other folks and me, and that we could potentially create a consortium that would be able to do what we currently do for children, but also for adults. It was originally envisioned, and the original, David, I even looked up Senate Bill 63 today, the original bill that was put out in early 2019 around that. So Tom met with David and me to say, hey, can we make a big ask? And so we thought a big ask would be $100 million. And Tom was like, yeah, I think we can. And so we made this plan to go see Senator Nelson, and it was David and Tom and me. And Tom was in charge. David, don't you agree that Tom was in charge of actually saying the phrase $100 million?
Yes, he was. Mhm.
Yes, yes.
Yeah.
Well, so we got in there, and David, gave a great introduction. Tom did his part, and then he handed it off to me, and he hadn't said the $100 million. So I had to like take a deep breath and say $100 million to Senator Nelson. At which point she exclaimed, "Oh my goodness, that's quite a bit." But yes, I think we can do that, which made me think, of course, we should have asked for more. But Tom, that was classic Tom. Like Tom would get us in there, but Tom would make sure that like he got people like David and me and folks like you all to do his work. So we're all actually part of Tom's movement to make the world better. And everything that's happened since with the consortium really started there. And so Tom, he's just been indispensable. And up until he died last Saturday, he had been still advising us, still advising Texas 2036. He did start telling me in the last couple times I met with him earlier this summer that he was feeling tired, but and I think he told me no for the first time of a favor I asked him, but he would still get on the phone during our meetings and like, help somebody sort through something. So he's a great role model, I think, for, if you have a life of service that you can partner with people. If you don't mind who gets the credit, you can get all sorts of things done. So his funeral is a week from this Saturday in Dallas. That would be, I guess, Saturday the Saturday the 15th of August at St. Michael's and All Angels Church. It's not a very big church. It only holds about 1,000 people. So if you actually want to go there, you should get there early. Um, but it'll be live streamed, and we'll get that information, David, out to people. And there's been a lot of remembrances of Tom, and I'm sure many people here have remembrances of him as well. But I just wanted to, I guess, thank you, David, for the opportunity to share. And I think those are the main
Yeah.
things I wanted to say.
Yeah, huge footprint in the state of Texas, from being part of Sunset, establishing the Meadows Mental Health Policy Institute, to, again, being in that key meeting that we had with Senator Nelson to get this up and on its feet, to establishing 2036, which is housed in this building, which is planning to make sure that how do we position Texas for our 200th year anniversary, and what do we need policy wise? And so huge, and one of the nicest men you'd ever want to meet. Dr. Martinez, I see that your hand is up. Would you like to say something?
David, yes, I would. I just want to say Tom was truly a tremendous individual. He was so kind. He also was an individual, many don't know this, with lived experience. Mental health meant a great deal to him and to his family. And it was a real pleasure with Linda Evans, Andy Keller, and myself to bring him on board as the president of the Meadows Mental Health Policy Institute in the early days. At that time, I was the inaugural chairman of the board. And so working with him, with Andy, and everyone else we brought on board, really tremendous individuals. But Tom was able to bring everyone together, and then just his expertise as a statesman. I can't, to Andy's point, I can't say how tremendous that was to launch the Institute, which we all had worked so hard to bring to fruition, and then to give so much and to, in fact, help to create this consortium. So Andy, I thank you a great deal, because I know you worked a great deal with Tom, but the few years when I was chair of the board for the Meadows Mental Health Policy Institute was one of the best times I had working with Tom. We'd have great conversations. I learned so much from him. He's going to be sorely missed. He truly was a statesman who looked beyond just the parties, but what that state of Texas needed and what its citizens needed. We need more folks like him. Thank you, David.
Yeah, thank you, Octavio. Andy, a quick request for you. I saw a really nice interview between you and Tom Luce about a month ago that gave just very practical advice on how to be effective in getting policy changed. From how do you do a good white sheet, to how showing up on time, to how do you interact with legislators. And if you would send that to Nagla, I'd like to send a copy of that to everybody, just so you can see his advice from a very seasoned statesperson about how do you impact positive change in the state of Texas. Andy, is that okay?
Oh, David, I love that idea. And it's so funny. It's a great video, and it's a how-to. One of my board members sent me a note earlier this week after seeing it, saying, and I always wondered how a former consultant could actually, learn how to testify and do the kinds of things, because I don't think very highly of consultants. But now I see that you just got all this training from Tom, and you basically did what he told you to do. I'm like, that's exactly right, sir. So we can all emulate him a little bit. Thank you for doing that, David. I'd love that. Thank you.
Yeah, that'd be great. All right. We have several people that have joined us. Again, just want to be complete in the attendance. Dr. Amador, are you there?
Here.
And Dr. Martinez, we just saw him. John Scott, are you here?
Yes, I'm here.
Okay, very good. Dr. Thompson?
Yep, I'm here.
All right. Dr. Wakefield?
Yes, I'm here. Thank you.
And Dr. Oliphant? I think she is here. Okay. All right. Well, let's move on to item number 2. We can do this very quickly. The approval of the executive committee minutes from June 8th. Everyone could take a quick look, and then I need a motion and a second for us to approve them.
Motion to approve.
Second. Got a motion by Dr. Babato, a second by Dr. Nimrod. Any further discussion? Hearing none, all in favor of approving the minutes signify by saying aye.
Aye.
Opposed, nay. Did anybody abstain? All right, let the minutes show that we had unanimous approval. So this meeting is a little bit tricky for me in that I have another meeting that I have to join. And in less than half an hour. And so during that time I'm away, I'm going to have Dr. Nemiroff substitute for me to make sure that the meeting moves forward. But I'm going to juggle the schedule just a little bit to make sure that I'm here for part of the things that I think have more conversation around. And so I'm going to jump to section E and go to the policies. And now I'm going to turn this over to you and see if we can get through several of these policies before I have to jump.
Yeah.
Mhm.
And if you just bear with us for a couple of seconds, Anissa. So at the last meeting, we discussed some teach out policies and we voted on one and we left the remainder for this meeting to go ahead and approve. So the process was that all of those were sent back to the EC committee to review and to go ahead and identify whether there are additional proposed changes. I'm going to go through each one and we're going to talk about kind of what each policy covers and whether there were suggested changes and what those were. So for the first one, the school outreach and enrollment policy, this policy sets forth the guidelines for outreach to enrollment of school districts and campuses. The policy covers outreach process and documentation expectations, requirements for a memorandum of understanding with the school districts, onboarding activities and equipment, non-public school outreach and enrollment, and exceptions to the non-campus model. And we did not receive any proposed changes for this since last meeting. And I don't know if we should take each policy by itself and go ahead and.
Why don't we approve them one by one?
Yes, okay.
Okay. So we're going to do these one by one. Is there any further discussion about the school outreach and enrollment policy? I think everyone's had a chance to provide feedback. Okay. Hearing no comments, I'll take a motion to approve.
So moved.
So moved by Dr. Nemiroff. Is there a second?
Second.
I heard several seconds and I couldn't see who it was. Adam, unfortunately, I can't count you because you're the medical director, not the executive committee member. Okay.
It was Karen Wagner.
Karen Wagner, I got a
Yeah.
second from Karen Wagner. Any further discussion? Hearing none, all in favor of approval of the school outreach and enrollment policy, signify by saying aye.
Aye.
Opposed, nay. Did anybody abstain? Let the record show we had a unanimous approval for the new policy.
The next policy is to establish the guidelines for processing referrals and enrolling students into teach-out services. The policy covers referral sources, referral processing steps, expectation for intake appointments, and assessments that are required to be sent to students and or parents/guardians. For that, there were some input. So the key changes since last meeting, which is next slide, is updating an updated definition to align with the service and discharge policy. And that's related to active schools and intake appointments. So other than that, there were no changes.
All right, very good. Any discussion? Any hands being raised?
Nope.
All right. Hearing none, I'll take a motion for approval.
Motion.
Motion by Dr. Nemiroff. It's second. Again, I can't see. Can I?
Second.
Okay.
Dr.
Second.
Matthew.
Matthew? All right. Any further discussion? Hearing none, all in favor of the approval of the referrals and enrollment policy, signify by saying aye.
Aye.
Opposed, nay?
Yep.
The Did I get the wrong day? Okay, so take,
Referral and enrollment policy.
it's from enrollment, it says services and discharge up there.
It's
Yeah.
to align it with.
Okay, all right, sorry, okay. Let the record show we had unanimous approval. Let's go to the service and discharge policy update.
So the service and discharge policy is a policy that establishes requirements and guidelines for providing TChat services to students. This policy covers appointment standards and expectations, documentation requirements, including the session notes and the end of care requirements. It has the treatment approach, including intermediate services and bridge services, care coordination and case management, including referrals and community-based providers, timely access to care and transfers between HRIs. And finally, it includes also the mental health education and TChat training parameters. For this policy, next slide, there were some input and we've added this input. It wasn't to the actual policy, but more clarifying language on requirements for parent, guardian, or another legal authorized representation to be present in the home during home-based sessions. And then an updated definition that aligns with the referral and enrollment policy for discharge and enrolling students. So those two changes were made.
All right. Any further discussion?
Yes, Dr. Leakey, I have a question regarding this policy.
Dr. Wakefield.
Okay. Go
Yes.
ahead, Dr. Wakefield.
There's language in this policy that I appreciate about the transfers in between HRIs. And it references the intermediate services, but it doesn't reference, but then there's another part of the policy that says if that each HRI does not have to provide medication management. And so I was just interested if medication management would be a reason for transfer in between the HRIs as well, if the HRI does not have that service, or if that's something that we're precluding.
I'm gonna actually, I know that came up before, and I'm gonna ask Dr. Williams if she to address that. I mean, I don't see anything problematic about doing that, but Dr. Williams?
No, I mean, I think that our goal is always to try to get them to the next place if at all possible. But certainly if there's some barrier, just like for any other intermediate service, we could certainly talk it through. Yeah.
Okay. Do we need to make it more clear in the policy?
We can, I don't know, Dr. Williams, we can add a kind of clarification on the policy to say for intermediate services or any other unavailable services such as medication. Is that kind of?
I guess does the policy as it currently written mean that we can't do that, and so this is where I'm not like an expert in policy, or does it need to be explicitly put into the policy?
I think it might be better to just go ahead and add that in as a clarification, and we can always vote on it with that slight modification to it.
Then as long as the language fits with what everybody likes, I'm okay with it.
Okay. Very good. Any other comments? Hearing none, we'll take a motion to approve this policy with the edit that clarifies that one reason for transfer could be related to medical management.
Approved.
Okay.
Second.
Dr. Wakefield, second. Any further conversation? Hearing none, all in favor of approving the services and discharge policy, signify by saying aye.
Aye.
Opposed, nay. Anybody abstain? Let the record show we had unanimous approval. Okay.
And the next slide just shows the timeline. So we will be working on updating that last update and distributing the policy, and it'll take effect in August. Thank you.
Okay. The next item is for collaborative care management. There are two parts of this conversation, and I just want to be clear because we've gotten some feedback, actually got some feedback that this weekend related to various parts of it. But there is part of it related to the overall plan, and that's just review that we're going to be doing today. And sets up the time to get feedback, will hopefully be helpful in developing a plan to address some of the issues that I've heard related to kind of overall structure related to it. The second part just has to do with next year and making sure that there are a couple things that are done for next year before we get into the next legislative session. And so Nagla, or Claire, you want to walk us through it?
So good morning, everyone. My name is Claire Nide, and I'm the Workforce Project Manager for the consortium, and I'm also supporting the integration of the consortium's ARPA-funded initiatives into our core programming, which does include collaborative care. And today I'll be presenting a proposed redesign for the collaborative care model program within the consortium, and a set of FY27 transition activities that would prepare participating institutions for that redesign. And just briefly, for those who are less familiar with the program, collaborative care is an evidence-based model that integrates behavioral health into primary care through a combination of care management, psychiatric consultation, measurement-based care, and population health management. And then today's goals of the presentation, as Dr. Lakey mentioned, is to introduce the proposed future direction of the program, and then obtain approval for the limited transition activities that would support that implementation. So I'll start off with the first reading of the program concept and recommendations. No approval is being requested for these. We're seeking review and feedback before bringing it to the final proposal back to the committee, hopefully in October. And following today's discussion, we'll have approximately 1 month or so for the executive committee to review that and provide formal feedback. And then as part of broader planning associated with the conclusion of ARPA funding, just letting y'all know that UTS has conducted structured reviews of all ARPA funded initiatives to evaluate long-term sustainability and future program design. And collaborative care just happens to be the first program being presented through this process. So just giving y'all a heads up that similar reviews and recommendations for other ARPA programs will be presented to the EC in future meetings. So getting started into why the redesign. So the ARPA funded pilot for collaborative care has been extremely valuable. We found that it demonstrated that collaborative care can be implemented across a variety of settings and populations. And it confirmed that there is genuine interest in the model among participating institutions as well as their partners out in the community. And the pilot was conducted largely as a decentralized implementation effort, which gave HRIs considerable flexibility in how they approached implementation and provided partner support. And that flexibility helped launch collaborative care in a variety of settings. But it also meant that implementation approaches often evolved independently across institutions. And we have had limited opportunities for structured statewide learning, standardization, and collective problem solving across the HRIs, like we do see in a lot of our other consortium programs. And participating organizations also relied on different combinations of internal and local resources, external technical assistance, and of implementation support. And as a result, HRIs often serve primarily as coordinators of those activities rather than as like long-term implementation leaders and having that centralized focus for their work. So collectively, these lessons shaped the program recommendations that I will share today. The proposal places greater emphasis on stronger statewide coordination, shared learning, institutional capacity building, implementation consistency, and sustainability planning. And as ARPA funding concludes this fiscal year, we're also transitioning from a highly flexible federal funding environment to a program that must operate within the state's biennial appropriations process and demonstrate accountability, sustainability, efficiency, and measurable impact. And so really through this process, the question that we asked ourselves with this redesign is, how do we preserve the value of collaborative care while creating a program that is more sustainable, scalable, and consistent with the consortium's institution-led structure? And so the recommendations being presented today are a result of that review. Next slide. So here is a very brief summary of the core pieces are changing. I will state that this is not all inclusive. These are the bigger pieces. There are some things like that the program will remain voluntary and those kinds of things that were not included in here as they were not larger areas of discussion. But as the executive committee reviews through the formal review process, all parts of that document are open for review and feedback. But this slide summarizes the major shifts being proposed. At a high level, we're moving from pilot implementation project to a sustainability and capacity building structure. We're being more structured about timelines, more targeted in where we invest state funding, and more explicit about what success looks like for this program. And that's essential in a state-funded environment that we're moving into, where we really need to demonstrate that investments are strategic, effective, and sustainable. So first, the proposal expands the program from a pediatric-only focus to include both pediatric and perinatal populations, which aligns more closely with the consortium's target populations and creates opportunities to better coordinate with other existing consortium programs like PeriPan. Second, the program would mostly move from an undefined implementation timeline to a structured 2-year implementation cycle aligned with the legislative biennium. This creates clearer expectations for implementation, sustainability planning, and program oversight, while acknowledging that legislative appropriations ultimately occur on a biennial cycle. And by keeping implementation and funding cycles within a single biennium, we create a clearer, more predictable structure for both program management and legislative support. Third, our partner selection process would become more structured. A major lesson learned from the pilot is that successful implementation depends on much more than just a willingness to participate. And the proposal incorporates a variety of assessments of prospective clinics, readiness, operational viability, leadership support, and sustainability potential before investment decisions are made. For the funding philosophy would also shift. We're proposing a seed funding approach that focuses on startup infrastructure, implementation support, and sustainability planning. Under the pilot, ARPA funding was highly flexible and was used to support a very broad range of implementation activities over multiple years with the intent of support until financial self-sufficiency for those clinics. But as we transition to more restrictive state funding, the goal is shifting to be more clearly define and prioritize allowable uses of funds so that public resources are used efficiently. Partners are encouraged to progress towards self-sufficiency, and the program can demonstrate measurable value and impact to both the legislature and stakeholders. And this shift reinforces the expectation that consortium funding serves as a catalyst for implementation rather than ongoing operational subsidy, while allowing resources to be focused on the activities most critical to successful and sustainable collaborative care adoption. And then one area intentionally left for further development within the funding section is the detailed funding framework. Based on stakeholder feedback, we're recommending that the funding cap amount and related funding parameters be developed collaboratively during FY27 rather than coming to y'all with a recommended specific dollar amount today. For the fifth one, from a governance perspective, we're recommending dedicated UT system project management and statewide oversight. Essentially, that just means as the administrative support entity, we'll assign a project manager from within our ranks. Most consortium programs have a hub or program lead that provides statewide coordination. And so for the collaborative care incubator program, we believe a dedicated project manager is the most appropriate approach given the size and structure of the program. Sixth, another important change is increased standardization through implementation resources, guidance, and cross-HRI learning opportunities. And this is intended to improve implementation consistency, reduce duplication of effort, and allow successful practices to be shared statewide. And then 7, perhaps one of the most significant recommendations is the shift in the role of HRIs. So rather than primarily coordinating partnerships and funding, HRIs would become more regional implementation leaders and subject matter experts through this program. The incubator program centers HRI leadership by building capacity within their institutions, equipping them with the skills, tools, and experience needed to lead implementation across their regions. This approach aligns with the consortium's institution-led structure and legislative expectations of the works of the consortium. And through this concept, HRIs become the primary drivers of implementation, which does expand their reach and deepens their role in supporting clinics. It also creates stronger opportunities to align with programs like CPAN and PeriPAN, enhancing coordination and amplifying impact statewide. And this strategy invests in durable system-level capacity, so implementation capability lives within the system that we have here within the consortium and can be sustained and scaled over time. And finally, the evaluation approach would be broadened. Instead of focusing primarily on patient-level outcomes, the program would evaluate implementation progress, fidelity to the model, sustainability, organizational capacity building, and overall program performance through a comprehensive statewide evaluation framework, which would be to be determined, that would be collaboratively created. And so collectively, these recommendations move collaborative care from a pilot project toward a sustainable and scalable statewide program. And really quick, just to point out a few things for the HRI leads that did participate in the original review. Want to be clear that we did include changes related to and requested by the HRIs regarding the ability to not move, what would be the best way to say that? Ability to cross biennial periods with either funding and or activities. We did write this as not a standard program allowance, but rather an exception that is based on things that are out of HRI's controls, like contracting delays or something like that. And so all of this is also dependent on legislative approval and appropriations. That is first and foremost before we can make any determination. But that was included for the scale of that. And I believe that was the key. Oh, and then just to clarify for technical assistance, the recommendation remains unchanged, but the rationale was expanded for clarity. The current proposal permits the use of external technical assistance and does not require its elimination at any point during the program. And so we clarify that this remains allowable and ongoing resources for specialized expertise, consultation, or strategic support as needed. I believe that is it for that piece.
So for this piece, and to be clear, there isn't a vote on this piece.
Correct.
That this is where folks are in the discussion. Want to get more information back from everybody related to the proposals. You have a month to do that. And then at our subsequent meeting, we would have a vote related to those updates. Any question related to that part?
Luann Southern, I have a question. So it sounds like the outcomes based on the funding that we got from ARPA to do this are good, which is justification for continuing to sustain what was started with the ARPA revenue?
Yeah, so I think this is a natural maturation of a pilot project that was funded by the federal government, that you learn things, and then there is this transition between federal funds and state funds, and with that, there's different rules that have to be put into play. And so making sure that we work collaboratively with everybody to make sure that we get this in the right position. Yeah, Charlie?
So I just want to say how important this program is, but it's also extremely complicated. So understand that collaborative care is the future of American medical care, but it involves, by definition, collaboration with pediatricians, primary care doctors, OBGYN, et cetera. It will require, as we move from a pilot to a full-blown program, it will require a tremendous amount of medical input from members of the consortium and even those outside. And this is sort of God's work, because this is going to make a medical psychiatric care better for children. And now we're including women during pregnancy and in the postpartum period. This is no small task. At Dell, we have three partners that we've done the pilot project with. They each have their own structure, their own politics. Luann shaking her head. She understands. And so this is not trivial, right? And to convert this from a funded project to a sustainable project is going to be a feat, right? We can do it, but we really need to be thoughtful about it. And I just think we're going to need a fair amount of time to digest this and come back with recommendations.
And that's the recommendation,
Yeah.
is that this is starting that discussion to the next level and come back. Andy, why don't we go to you, and then I have to run to the next meeting that I have. Andy?
Yeah, thanks, David. Well, first of all, I really appreciate Claire's leadership on this, the work group's work, all the input. This is great, and this is exactly what the original vision was to have this be really, as Claire said, a catalyst for building HRI capacity, recognizing that HRIs are going to vary in capacity just like they do on every other aspect of what the consortium does, and sometimes depend on each other. I think I just wanted to emphasize that I appreciate the chance for further discussion on this, because while it's great to have the UT system put resources on this and have a project manager, I think to achieve the vision that Charlie's just saying, we really do need to have more formal HRI leadership on this. And I think I would even go so far as to say we need to have something like an expert hub, if you will, or a lead HRI, just like we do on everything else, or maybe co-leads, that would make sure that there is that kind of medical oversight that Charlie was talking about. And also can make sure that this evolves. I mean, we do want more standardization in the expectations, but the reality is this is going to look very different in different regions of our state with different subpopulations, different payers. And so I just think having the kind of flexibility that's HRI specific around funding, and then HRI leadership, adding that additional infrastructure to the dedication of resources, which the UT system's already made through the consortium. I think those will be the two things that feel most important to me. I will just add, there's a huge amount of federal funding increases that are currently in the pipeline, even under the current administration, to make this a much more sustainable funding environment in which to be. So I think this is a great moment to do this, and it's very exciting to see this level of interest. So thanks for all your work, for your team, David, on this, and we're excited to be supportive as it goes forward.
Yeah. Now, thanks to everybody for your help, and thanks to the staff and everyone that's been working on these issues. And so I have to run to this other meeting. I'm going to stop the vote for the 2027 plan. We're going to have to come back when come back, and then we'll resume that conversation. And so while I'm gone, Charlie, I'm going to have you continue the conversation and go back to the beginning and do some of the things that we skipped over. And then when I come back, then we can go to that vote part.
Okay.
Okay? Thank you.
Thank you, David. Octavio, you have your hand up?
Yeah, thank you, Charlie. I just wanted to put my voice in as well in reference to collaborative care. It is a game changer, and now taking it to this next level is really critically important. The Hogg Foundation in 2004, we actually funded Wayne Caton and Jürgen Unisser, 6 pilot sites in the state of Texas that showed that fidelity of the model, this collaborative care, really does work. I think it's exciting, just like Andy mentioned and Charlie's mentioned and others, how now taking it to this next level and making it really part of the full infrastructure of behavioral health care will actually really benefit the state of Texas and our citizens and communities tremendously. I think it definitely is sustainable, but we do need to be very conscientious and strategic in that approach. And definitely want to add that it's going to require good medical oversight as well. Just thinking about maybe a medical director as we're thinking about putting together an overall plan. I think, like Andy mentioned, the hub, and so is Charlie. So as all of us are thinking about this, keep that in mind, because fidelity of the model is what ensures that actually it has the impact, not only for health outcomes, but for the sustainability of the model.
Well, Octavio Wayne was one of my close friends, and we lost him too early.
Yes, we did. It was a great loss, Charlie. I totally agree.
Yeah.
Yeah, just a couple of things. So between now and the next executive committee meeting, are we going to take a vote at the next committee meeting? Because there's just a couple of things that I would really love to see in relation to this. First off, I would love to see the outcomes just from the initial implementation with the ARPA revenue. How do we know that this is working so that we can see the success of the collaborative care initiative that was financed through the federal funding that will help provide the impetus for the ask to continue it and sustain it using general revenue. And then the second question that I have is this going to require an appropriation request for the legislative session that's above the amount already appropriated? So it would be above the base funding that's already appropriated to the consortium. Those are just two things that I wanted to add.
I can start first, and then Alex and Claire can pitch in. But currently, the outcomes as they were looked at are patient level outcomes. So they, and this is a clarification that we are not evaluating collaborative care model. We are assessing whether we are able to have a clinic actually sustain collaborative care model. So that's the shift. And because of that, we want to change the look of the outcomes to see, does a clinic, is one of the 10 clinics that are currently moving forward with collaborative care able to sustain it without continuous funds coming from the state? And so that's kind of our shift, you could say, in focus, because that's the outcome that we want to show outwardly facing is, hey, we've been able to have this number of clinics, or these clinics actually sustain collaborative care. So that's kind of and there was a lot of infrastructure building during ARPA funds, and so we know that there's a lot of infrastructure building and understanding how to provide technical assistance and support the clinics. As far as funds for 28-29, it will be an exceptional item request beyond the base. It's not part of the base, and that is not our conclusion. That is the LBB's conclusion. Alex? Okay.
Open. Please.
For clarification on your first point. Okay, you're on.
Sorry, I haven't been in this room lately. I did want to see clarification again, what you said. So the focus will not be, I want to make sure I heard this correctly. The focus will not be on the patient outcomes. It will be on the, that's like, I'm sure I didn't hear it correctly, so I wanted to clarify.
Let me clarify it. So the clinic focus in implementing and following collaborative care is on patient outcomes. Our focus on determining where we successful on implementing, so we're not implementing collaborative care model as in, within our parameters. We're helping a clinic implement collaborative care. So our success is the clinic's success of implementing collaborative care, if that makes sense. But part of implementing collaborative care, and for the clinic, they are successful at implementing collaborative care if patient outcomes are improving, if they're able to bill, if they're able to collect information and see what's happening with the patients and integrate behavioral health. So those are all part of being successful at implementing collaborative care. What I'm saying is our piece of it is to make sure, and that's the reframe, again, that people will be voting on, is that we're wanting to make sure that clinics are able to implement collaborative care, which includes all of those things, including patient outcomes. It's just the relationship is between us and the clinics, if that makes sense. Is that?
Is that okay,
Go ahead.
Hilda?
I understand what she is saying.
Okay, thank you. Jason, you have your hand up.
I do, thank you. Just wanted, in the interest of transparency, Children's Health operates a similar program in the collaborative care space called Behavioral Health Integration and Guidance. It is currently funded solely through philanthropic funding through our foundation. But I think it's close enough to sort of what this program is aiming to be that I needed to, first of all, let you all know that. And then secondly, ask the question if it would require you to abstain from any votes, particularly regarding funding.
Let me check with our attorney here.
Well, we're not voting today.
Oh, yeah.
So, you know,
Yeah.
we can invest.
We're not voting on this today, correct?
Yeah,
So don't worry, Jason.
Okay, thank you.
or we can look into it in the.
We'll get back to you on that.
Thanks, appreciate it.
Dr. Raji is, oh, sorry, Dr. Ibrahim.
Yeah, I just wanna, I mean, measuring outcomes is gonna be very important. As you think about feasibility and sustainability, there is not gonna be any financial model that will be positive for this. This is not, we've tried that. It's not gonna be, we're not gonna come up with any financial model and be able to independently support behavioral health. It's gonna be something that will have to be supported financially otherwise. There's no billing model for this. So.
Huh. You need to talk to my dean about the issue of sustainability. I've said what you said many times.
Well, and I'm talking about it as the lead for our institution for ambulatory services at large, specifically for psych integration, that kind of integrated. This becomes a health system university decision about whether to support that kind of approach or not.
Yes. Dr. Raji?
Yes, I mean, in a way, my comment is kind of along the same lines, which is kind of what, other than the patient outcome, which we all kind of agree on, I think what we need, I hope over the next month before we get to a vote, that we land on what is that target of sustainability that will probably incorporate some deficit on the health system that we can live with and consider that that's going to be our target of success. So in other words, what is that deficit that we're going to be accepting? Because the sustainability, self-sustained clinics with the billing, that's my understanding where the really bottleneck of maintaining those programs. So if we accept the fact that, kind of to Hisham, Dr. Ibrahim comment, that we need to accept certain deficits. So what is the magnitude of that deficit we're going to be accepting? So hopefully that becomes, discussed and clarified over the next month or so.
Well, I think based on the planning process, we're going to get a lot of input here. And I think we have a goal of sustainability, and the planning group, which will be put together, as I understand from Dr. Lakey, will come up with much more data to address your concerns, Dr. Raji. Dr. Plitzka.
Oh.
Yes, sir.
I think the sustainability issue is a thorny one. And I think one thing, what Claire is saying, or what the consortium is saying, is that subsidy will not come from the consortium long term. That you have got to develop the program, see what it collects from billings, and then that institution, that pediatric clinic, needs to decide, if there's just no way for it to break even with billing and collections, then they've, find a philanthropic donor to support it, just take the loss, make it a loss leader, because it saves money in other areas. For instance, kids don't get hospitalized. That's a huge saving if it's a contained system. But someone in that system needs to do that analysis and adopt that. I know I'm having that discussion where there's people in my health system that I'm working with can say, well, it's nice to have it, but, can't you just keep funding it forever? And I said, no, we can't do that. And that's a hard conversation you sometimes have to have with your partner. And so let's not, as we get into this, let's expand it. let's refine it, let's make it as efficient as we can, but let's not go into it thinking, well, the consortium is going to, if it doesn't make money, the consortium just needs to support it.
Yeah, just to, let's bring this conversation to a close, but just to follow up on Dr. Plitzka, many of the organizations that we partner with do get federal funding. And that federal funding will help us offset the cost of the collaborative care program. So if there are not any further comments, I'd like to move on. Great. So we're going to go back to page 1 up to program updates, and we'll start with CPW, Dr. Plitzka.
I have no slides and I will be brief.
Well, that's great.
That's great. So currently in my role as medical director, I'm kind of doing a grand tour of all of the 12 HRIs, meeting with folks who are involved in the program on the ground to give myself a real not a bird's eye view, a ground eye view of what's going on. And I really appreciate everybody being very flexible. And it's been great to meet all the clinical faculty who are supervising the residents on the ground. I've really been impressed by the work the folks are doing. And that process should be complete by the end of August. And that will enable me to identify some broad statewide themes. So the ultimate goal of these meetings is not to look at what necessarily to say, well, HRI A is doing this and HRI B is doing that, but rather to say, these are challenges and benefits that I'm seeing across the statewide system, and then the leadership group can take those up, particularly in cooperation with both our LMHA and our non-LMHA partners. And the second major issue is we've been working with HHSC on refining the monthly report for the number of patient visits and the number of unduplicated patients that are seen each month, so we can look at that in terms of FTEs and have a real good sense of what's going on, same way we do in CPAN and TCHAT. And I want to again thank the folks at HHSC. They've been very helpful, and I think we're just about there. We have, and I think the next report that goes out for the July data, I think will give us much more fine-grained data on which to make policy decisions going forward. And that's what we got.
Thank you, Stephen. Other questions for Dr. Plitzka? Let's move on to the CAP and OWE program updates. Yeah.
Thank you. I'll also be brief. I do have a couple of slides. While the slides are coming up, I'll say something I don't have a slide for. We're Claire and I, in early stages of organizing our thinking around the future of the other workforce expansion programs. But one thing that has become clear to us is that it needs a new name. And so we are moving forward with behavioral health workforce development. The previous name sounded a touch othering, as it were. So behavioral health workforce development. Next slide. The exciting things going on in right now are that after a lot of planning and a lot of work behind the scenes, we are this month actually launching several statewide didactic programs. So many thanks to Denise Bond, who's been the task force chair for the shared child and adolescent psychiatry didactics. You can see the schedule. We are starting with 4 sessions spread out over this year. And our first one is this coming Friday. I'm very excited and looking forward to hearing TCMHCC's own Sarah Wakefield. So that's going to be a terrific launch. Next slide. And I also wanted to share with folks that our disaster psychiatry workshop for trainees is also launching a week from tomorrow. We've got 4 sessions so that we can reach as many training programs as possible. And the response from training programs has been really quite robust and enthusiastic. So again, a great deal of appreciation to Kaylee Davis-Bordowski, who's been sharing that effort. And I think that that's it for me.
Adam, I had a question related to OWE or whatever the new term is going to be. Is that category include all brands of mental health practitioners? That is the OWE program. Can one use funding from that program for psychologists, social workers, non-MDs? Is that it's
Yes,
broad?
It currently, so it's also in the category of things that have been funded by ARPA, and it now will need to move into some sort of long-term sustainable and really state designated funding. But it's absolutely meant to embrace and encompass every kind of mental health clinician on everybody's teams. So there are currently programs for APPs, social workers, PhD level psychologists, master's level psychologists and LPCs, family therapists, and
NPs?
What's that?
NPs?
Yes, under the APP.
Okay.
Yes.
Okay.
Yes, exactly. There are several advanced practice provider fellowships, and currently the ones in Texas, each of them is open to both PAs and NPs.
Questions for Dr. Brown? Yes, Luann.
So this is really awesome because we know that the behavioral health workforce is hurting right now in terms of shortages, et cetera, but I'm curious about, I know that some of the schools of social work, for example, are very interested in knowing how they can partner with the consortium on some of these initiatives so that graduates or students in those particular programs can also participate and be part of the efforts that are happening through the workforce development. And I'm wondering if you all have done the outreach to some of the schools of social work, schools of psychology, et cetera, across the state within our health-related institutions to kind of partner and look at how we can expand what we're doing into those schools as well. I'm just curious about that.
We haven't done it at the OWE program level. It has been done by, excuse me, some of the specific, for example, social work fellowships. We have one at UT Southwestern, which just graduated its first pair a couple of months ago. And so we've reached out to some of the local schools as well. But that's been more in terms of, I think the kinds of connections that have been made have been more in terms of pipeline and referral, and not so much in terms of really building integration into the MSW programs themselves. And personally, I think that that's where the future efforts should go. I think that the programs for post-degree fellowship should be find ways to be connected directly to the degree programs.
I think there might be some interest from some of the universities with that.
Please send anyone my and Claire's way.
Okay.
Thank you.
Dr. Wakefield.
Thank you, Dr. Nemiroff. Luann, I was just going to share that we have relationships at the MSW and the LMSW level here at Tech, and I think it's been wonderful looking at those placements. It does take a lot of coordination, but it's a really fruitful kind of thing to do. But I can't imagine that. I think it really has to happen at the HRI level because of the differences in availabilities and what the schools, what their needs are, really looking at them as more like their field practicum sites is how it's worked best for us.
Well, thank you, Sarah. As long as you're on the dais here, can you go forward with the Peri-Pan update?
Absolutely. Happy to. If I can get some slides up. Wonderful. And I am excited to do the Children in the Law talk. It's probably the most complicated talk I've ever put together, trying to put together answer all the questions that our fellows wanted to know about practice. So I'm excited to see what happens this Friday as well. We'll get some feedback and see how it goes. But all right, thank you guys so much. You'll see it as this first picture we wanted to include. Postpartum Support International had their conference a few weeks ago. And right before that, Lifeline for Moms, who's kind of the organizing body of all the perinatal psychiatric access projects in the country, facilitates the cross collaboration discussion amongst all those programs, had their summit right before the PSI conference. And so these are not even all, but the majority of the folks from Texas, from across all of your different HRIs and all of our different programs for PeriPan who went together to the Lifeline Summit and to PSI. So there are a few people not pictured here, but it was really such a phenomenal time for us to all be together and really thinking about perinatal psychiatry access projects, what it means, what are the standards in the country. And what I wanted to share here, and I will try not to be too boastful because we're so appreciative of the facilitation of Lifeline for Moms and all the framework and the groundwork that was laid in Massachusetts for all of us to go forward and do this work. But Texas had a big presence there, and there was a lot of discussion about the cool, innovative things that we're doing. And I just want to start off with saying how appreciative I am to all of the reproductive psychiatrists, all the behavioral health clinicians, all the administrative staff, all of the chairs of the different departments, and all of the work and the consortium, and just this opportunity, because we are a leader now in this space in a very short amount of time. They were talking about programs, where they were new or established. And it was very clear that even though we have not been doing this for that long, that we were considered a highly established program in the country, and really doing a lot of phenomenal work, and innovative work, and just really meeting the needs of Texan women who are pregnant postpartum and trying to do the very best job we can. So I appreciate that. It was very renewing to me, and I think to everyone there, and so nice to be there with everyone. So appreciate the time that we had together, and wanted to share that back with the chairs so that you were aware just of this phenomenal time we had. Next slide. All right, so here's our enrollment slide as it goes up. So we are almost at 50% enrollment of the obstetricians that we have in Texas. So we continue to work towards higher numbers there, and you can see this trajectory increase over time. It's something we continue to work with our teams and one-on-ones and our monthly meetings about, is how to make this number go up a little bit more dramatically. We'd like to see a higher enrollment, but we are really excited that, about having almost 50% of our OBs enrolled in this project. So just keep thinking about how we engage additional obstetricians. And I know all the teams are working on this, and this number is, it's really hard to connect with our obstetric colleagues. They're very busy, but how do we do this and make sure that they know that this service is available to them? Next slide. So these are total consultations. Again, you see in the dotted line for 2026 that we have, we're above any place that we had been in 2025, and that was dramatically above where we had been in 2024. So continue to appreciate the work that all of our teams do to get the word out, remind teams that we exist, these very, very busy clinicians, that we are here to help support them in the perinatal mental health of our moms in Texas. And I think that is, you can look at average and then to date. So we continue to be happy with this call volume, and yet not satisfied, and want to continue to improve. Next slide. This is our graphic just looking at how many of our calls go to psychiatry, our reproductive psychiatrists within the PeriPan program. As a reminder, when we look at the implementation, most of the work done from Lifeline or Massachusetts is looking at the practice behavior change. And again, an access project is of course about helping the patient that is being called about, but it's more than that. It's much more than that. The actual evidence base and the Access Project is in the practice level change that happens with the clinician with whom you're talking, and so that they actually have more expertise and confidence in going forward with the standard of care for other patients about whom they're not calling. And when we look at that practice level change, that the call for resources is helpful at that patient level, but it doesn't seem to impact the practice change. So it does serve a purpose. But then the discussion with the reproductive psychiatrist drives practice change more. And then another reason that we look at our direct patient consults is that seems that evidence-wise drives the practice change even more. So in the country, typically at least about a third of the calls go to the reproductive psychiatrist. So we have been really excited that our teams have exceeded that. So we expect that we are, if we're drawing down from evidence base, that we are creating a lot of practice implementation or change here, and really helping our obstetric colleagues know what to do and build confidence to treat all patients, not just the patient about whom they're calling. So 53, 47, 50% of our calls over the last 3 months have been a call between the clinician and the reproductive psychiatrist, which is something we continue to really like to see. Next slide. And these are direct patient consultations. So we had, again, we see a really clear pattern with our child consults and CPAN. We do not see a clear pattern in our reproductive or our women's mental health consults, except that it looks like over time, June seems to be a lower time. And so we continue to see that, and maybe that December time too. So, so we're seeing that a little bit again here. We hope and expect that this will rebound and go back up. But overall, as you can see, this is an upward trajectory of those direct patient consultations where our reproductive psychiatrists are actually seeing the patient through a telehealth visit face to face, and then able to provide really direct guidance back to the obstetric clinician about next steps and diagnosis. So this is that piece that I said looks like it drives practice change even more than just talking to the reproductive psychiatrist. So we're excited to see this continue. Next slide. I think I already talked a lot about this Lifeline for Moms Summit. Here's another picture of all of us. I think this did include all of the individuals that attended the Lifeline for Moms Summit. And really thinking through, we were able to hear we were able to share what we're doing in Texas. We were able to hear what other access projects are doing across the country, and think about how we might apply those things to Texas where it makes sense. And then just really grateful again for all of the participation from our Texas colleagues here, and really showcasing. Someone made the comment, and I don't say this lightly again, because there's so much importance of the partnerships and the collegiality in this group as we move forward and identify best practices across the nation. But someone said they should rename this conference Texas and All of Its Friends. So we were really excited to be there and be the friendly people we are, and to drive innovation and think about practice change and how we best help women in Texas so that they can raise the healthiest generation we've ever raised. That's our goal. Next slide. Thinking about, again, an update on HB18, you probably will get a different update on this later, but one of the things that we've been doing under HB18 is really letting reminding rural clinics that we are here for them and that we are excited to provide them this service, but also our list of rural hospitals that we now can provide PeriPan and CPAN services to in consultation. And we have been partnering with our HHSC and Torch colleagues to identify what are the best ways to get this message out to our rural and community or rural hospitals and clinics. So one of the things that I've been committed to doing, because I live out here closer to all the rural folks, and that's a part of our mission for sure at Texas Tech, is some windshield time, driving out there to partner and give some presentations to hospitals. So wanted to let you guys know that we have been doing a bit of driving around rural Texas in finding where these hospitals are gathering for other presentations, usually with HHSC, and getting in the room, sitting down and having lunch and talking to them about how we can partner together to help take care of our kiddos and our pregnant and postpartum moms who might be presenting in urgent crises or urgent scenarios to our hospitals or otherwise to our rural health clinics as well. Next slide. That's it. That's all I got.
Well, thank you very much, Sarah. Are there questions? Dr. Keller?
Yeah, thanks. Well, Sarah, thank you so much. This is a great program. It's so exciting to see, and it's so cool to see it unfolding. And I think it's also a really good example of a program we were able to use ARPA dollars to stand up, and now we're transitioning over. So I guess I just kind of wanted to just talk about the context of from our collaborative care discussion earlier. So I guess two questions. One, will the funding for Parapan also be in an exceptional item because it's not one of the core services? And then two, is there a plan to work with the UT system on similar standards like Claire was going over that we've done for collaborative care, recognizing that I think you are, Sarah, right, the lead HRI on it. So there already is sort of an HRI expert hub, but can you comment on those two things?
Nagala, I wonder if you want to comment on those two things.
Yeah, I'll comment on it. So on PeriPan, it is an exceptional item as well. So everything that went through ARPA is an exceptional item. So to list those include collaborative care model. It includes PeriPan. That includes other workforce expansion and YAM. So everything that was in ARPA is an exceptional item. Secondly, yes. So on collaborative care model, as we said, we will be discussing it within the work group to even talk about that structure. Currently, there is a work group of the leadership within each HRI, and it includes also Meadows Policy Institute representatives. And that is the work group that would continue. As far as identifying kind of the leadership and the structure, we will not discuss it at this meeting right now. We can discuss it as part of the input related to that. So provide us, please, your input related to the overall structure of collaborative care model based on the document that will be circulating again.
Other
So
questions?
I'm sorry, Naga, I didn't.
Sure.
Can I just clarify, Charlie? That wasn't.
Sure.
I didn't mean. I didn't want to go back to the collaborative care. I meant for PeriPan, since
Yeah.
PeriPan is also one that's being brought in. Will there be a similar sort of standards development process? Will there be the same sort of
standards-
formal review that
Right.
was done for collaborative care?
So with PeriPan, because it is, it kind of built on CPAN. And I don't know if you remember when we piloted it, we went through a whole process of kind of figuring out what the structure needs to be from the get-go. And it was very much based on CPAN. And then we also looked at, we had other similar implementations around the US. As Dr. Wakefield talked about Lifeline for Mom. And so we consulted with on the national basis to figure out what that structure looked like and also implemented based on our experiences with CPAN. And so a lot of that structure already now exists in PeriPan, where we do have a project manager on the I forget which agency I'm with now. No, with UT System, we do have a project manager assigned to PeriPan. That is Ashley. And then we also have a medical director similar to CPAN, the way it's implemented. So that's Dr. Wakefield. And then we have ongoing meetings, including leadership groups, and incorporating it similar to, again, CPAN. Dr. Keller, is that kind of answering your question?
Yeah, perfect. And so that I'm so glad that I asked because I do think that's exactly what needs to happen on the. I mean, that's exactly the template going forward. So it's so great that we have PeriPan already kind of blazing that trail, and then we can kind of continue down it. That's great. Thank you.
Okay, thank you.
Thank you, Andy. I think we're going to move on for the sake of time, and we'll go on to Kosh and CPAN program update.
Howdy. Can you hear me okay?
Yep.
All righty. I'm waiting for the slides. Next slide, since we're wanting us to move at a clip. Okay, so the actively enrolled physicians that we have, as you can see, there's been a steady upward trajectory. I would just echo what Dr. Wakefield's saying. OBs, family medicine, pediatricians, all of the above are extremely busy people, and we have a lot of really great team members across the state who are steadily going out to their places of work and their clinics, talking to them, talking to their support teams. And so we obviously continue to want to see that number continue to grow. Next slide. This is a super busy slide, and probably at some point we're going to retire it because it can be a little hard to read personally from my perspective. But as you can see, the dotted line is the line from this current year. And in general, we continue to see that we're having steady growth with our CPAN sort of consultation volume across this state from month to month. Every summer we have the summer dip, as all mental health for children anyways, usually has a sort of a summer dip. And I just looked at the August numbers, or sorry, July numbers, and there is another upward trend. So as we start to get back to school, I certainly anticipate that we'll continue to see an increase in volume once again. And we're still doing very well with our call back within 30 minutes when a primary care clinician and their team asks for it. Next slide. Similar, but maybe a little bit less than sort of peri-pan, we continue to have about a third of our calls go to our child psychiatrist across the state, and that is sort of in line with the information that Dr. Wakefield presented related to what is the evidence for change behavior within collaborative care models, not collaborative care models, CPAN sort of type models, is sort of making sure that we can talk to that physician, walk them through decision making. I think the direct consultation piece has really improved also in that regard as well. Us being able to see that patient one time and provide even more specific guidance has also been very helpful. But just for our first leg of the call, about 30% of our calls go to the child psychiatrist. Next slide. This is the number of direct consultations, and you can see despite the summer slump, we are continuing to see an upward rise in the number of times that we see a patient one time for that direct consultation within CPAN. Next slide. Things that we've done recently, we actually just launched, so we were having a pilot of the PCP portal. That is the web-based way for clinicians to put in their consultation request. It is not an asynchronous consultation. It is actually a request for us to help them with a particular situation case. And then we do all the same things that we do, which is calling back, organizing resources, considering a child or reproductive psychiatry call, and doing direct consultations as needed. But what the portal also provides clinicians and their teams across the state is the ability for them to see assessments that we might suggest and recommend. Speaking of evidence-based, measurement-based care, we can send out measures for them to consider providing to their families and to the women that they treat. We can also share documents through a secure process. So that portal launched this last week across the state to all clinicians who are enrolled and their support staff who are enrolled in CPAN peri-pan. At the same time, simultaneously, we have an engagement tool within the platform that allows for our team to send send messages through emails that have all of our appropriate logos and brands on them. And we use the communications team sort of support in creating the types of messages that we want to send out through the engagement tool. And so it allows us to sort of monitor how frequently are people opening our messages, if ever there's any bounce back, so we can maybe call to that clinic and get a better way to reach them via email. And so our first use case of the engagement tool was to sort of announce sort of the launch of the PCP portal. We were very excited to see some really nice open rates for our message. So we do think that clinicians who are aware of our program don't mind opening a message from us and reading it. So that was nice to see. Additionally, we also continue to, provide that education for CPAN peri-pan. And so our CME series, which includes webinars and echoes, is launching for the new academic year in this next week. So we're very excited. If you're ever curious to know what it is that we're doing and you don't happen to be following us on any of our approved social media, you can go to the website and see which of the topics for peri-pan and CPAN are available. We also are creating enduring materials for those webinars, in particular for both CPAN and peri-pan, along with SafeTA. So there's lots of ways for clinicians across the state to get educated in child and women's reproductive mental health. And we're excited to be offering all those activities for them. Next slide. So that was CPAN. I'm going to move to T-Chat. You can if you have questions, which I doubt. If you do, I'll answer them at the very end. As you can see, a more obvious trend for the summer decline. I do want to always point out that even though we have less referrals in the summer, we still continue to see patients. So we still get some referrals from schools, and we still have families who are actively getting treatment while we're in the summer months. We do not stop the service simply because schools are on summer break. Next slide. So this just follows with less referrals. There are less enrollments, but once again, we are still continuing to see patients. Next slide. As you can see here, we're continuing to see patients, and you can see the number of treatment sessions from month to month over the last several years, as well as the overall sort of number of students that are being seen. So we're still continuing to see a significant number of kids. So our staff are still very busy over the summer for T-Chat. Next slide. We have sort of been looking at sort of our parent response to the end of care survey. And so this is just sort of data showing you, speaking of outcomes, one of the things that we do a look at related to outcomes for T-Chat is how well parents and youth feel like the services were helpful to them. So this is not the outcomes of that. This is just did the family complete the survey? For all of you who know, when you get done with something and somebody sends you a survey to please tell you how you did, you can decide for yourself how often you open those emails and actually fill things out. So we are continuing to kind of collaborate with the internal evaluation team as we look at sort of the parent response rate and the child response rate as well. Next slide. Projects that are in process. One of the things that we do in T-Chat is we do measurement-based care. And so we have a series of assessment tools that we use at the beginning of a start of a care with a clinician and the family and the patient. And then as they have their services sort of end, we look at those assessments. We worked with the Laney and the UT system communication as well as the CHC to kind of craft some improved messaging that will go out via email and text to families to kind of encourage them to go ahead and open those things and go ahead and fill out those assessments so we can get much, even greater response when it comes to the assessments. We are working with UT system team to develop those needs for the HR to start HB 18. And that is slated to start in the sort of new school year in September. We are working with HRIs to kind of implement the goals that they developed for themselves during the T-Chat Summit that happened just 2 months ago. And we have sort of kind of in our final review for completing some presentations through the help of Laney and UT Systems Communication and the CHC to create slide decks for both counselors and parents related to anxiety, trauma, and substance use. So that's been really excited. And we are continuing to have a work group to build out some ways that we can do communications through trait, similar to how we do that now for CPAN, Peripan, for parents and schools. And that work group is not finalized yet, but is in progress. I think that's it. Yes.
Well,
Question?
thank you. Thank you, Dr. Williams. I think we could entertain questions about both of the summaries. Let's see, who has a question? Oh, Luann.
Sorry. So, Lauren, I'm excited about these trainings that you talk about on trauma, SUD, and anxiety. And I'm wondering, are those going to be posted on the consortium's website so that any interested person who might want to know more about those specific topics can access information? Like, for example, I work for DFPS, and it could be that foster parents might want to have access to information about trauma and children's mental health, just as an example. And I'm wondering if we posted those trainings online, it could be helpful for people to have access to them, just to from a learning perspective. Because I know you talked about them being available for parents, and I was just curious if they were going to be just posted so that people could see them and learn about different topics.
So the current iteration and process is that we are creating a standard DEX so that when our teams get a request from a school to go and teach on particular topics, we have created some evidence-based presentation decks that are built to really teach that particular population. And so at this point, I don't think we had envisioned that they would be sort of standalone, that somebody could just go and watch on the website. Certainly can take that back as information for us to kind of all noodle on. But at this point, it was more once a school asks us, hey, could you come to the school and present to the PTO on a particular topic, or hey, the counselors are asking to learn about a particular topic. That's sort of how these current decks are being envisioned being used.
Other questions for Dr. Williams? Thank you, Dr. Williams. We'll turn this over to Nagla, who will give us the governor's report update on TCHAP.
So this is the governor's report is a report where we're looking at especially kind of how the schools are engaged with TCHAT and which schools are active and which schools are working on becoming active. And then for those schools that decline joining or utilizing TCHAT, what the reasons are for that. Currently, we have continued to increase the number of schools enrolled, and we're at about 81%, a little bit over that, of schools are enrolled in TCHAT. And that translates to almost to over 84% of student population in Texas have access to TCHAT. And then there are about 350 schools that are in the process of being onboarded, as well as 23 that are planned. Next. For those that are planned implementations, most of those are associated, I guess, or all of those are associated with UT Southwestern. So usually this chart will show all the institutions that are planned. Next. So this is the TCHAT MOU status, and it shows it by educational service center. And so you could see where we are with each one. And in terms of also whether, and just to, if you can't see very well, kind of what the colors are related to. So that green, big green is those that are active. So you could see majority of the ESCs are active. And then the purple, which is the second largest one, are those who are unresponsive to outreach. So what happens is we continue to outreach, but if we can't outreach to those, then eventually they kind of go into a place where we hold off for a bit. And then, if they decide later that they do want, then we would go ahead and follow up with them. And that's we as in the institutions. Next slide. This is showing kind of the growth from the beginning of the student population over time. So we're getting kind of more at a steady state because most of the schools now have been enrolled in TCHAT. And then this goes into the detail. This slide provides you the reasons why institutions have decided not to or have declined TCHAT services. Majority of the reasons are related to having something else there that they feel comfortable with. And again, that may change sometimes. So we know that with ARPA having covered some of those behavioral health services within the schools, and ARPA funds at this time kind of finishing by the end of this fiscal year, that we might see some schools that might reach out to us because they no longer have behavioral health services within their schools. So again, it just outlines the schools and that are identified as declined, but as well as the reasons for the decline. And is that, I think that maybe it. Any questions about this report? Thank you. I'm gonna turn it.
Yes, Olga, please.
Quick question. Can you just clarify that the main data points that the governor's office is interested in seeing is TChat? So there are no other kind of programmatic related regular reports going to the governor's office besides TChat?
There are actually regular reports. There's a biennial report that comes out of the consortium that goes to the governor's office. There are occasional inquiries related to the status of certain programs or the consortium in general. This is one report because the governor's office had requested that the consortium goes ahead and implements TChat statewide, and they wanted to keep kind of abreast of what is going on and the status and what's standing in the way of going statewide. And that's why we provide also reasons for why schools have decided not to enroll in TChat, which, you know, so this particular report was a specific ask, but there are definitely other conversations and sharing of data. Sure.
Other questions? Great. Oh, Andy, I wouldn't want to forget Dr. Keller.
Well, thank you. So now, great. This is super cool. And I'm really glad we are tracking these reasons because things change over time. And I'm particularly interested in your point about with, a lot of post-COVID funds for schools dropping off this year. Is it possible to quantify what we've seen in terms of schools having increased interest in TChat now, or is it more kind of an anecdotal thing at this point that we think may increase over time?
I think it's a little bit more anecdotal at this point because, I mean, as we keep reaching out to the schools, I think that there's an ask of whether they think that this district or that district will join. But I think that we think that over time, as these services go away, potentially that might mean that they would come back. And I'm going to leave it up to also some of the institutions might have a better grasp of for their own areas. It's very specific to each area, each district, to whether they've heard back from that district. So we, we keep asking institutions to kind of outreach to those who have said, I have a program and that program is funded by ARPA, to understand kind of a little bit of whether we're expecting them to come back. We've asked those questions, especially during the budget meetings, to kind of figure out whether we're going to see a big sharp increase for certain regions because of larger school districts.
We're going to move on. Time is short, and we have the next section. We'd be on your toes. We have voting coming up. So let's move ahead with data and evaluation. First is the Dissemination and Publication Committee. Update from Dr. Plitzka.
Once again, be brief. We have one proposal pending, but there were no new approvals of any projects or manuscripts since the last period. So nothing particularly to report at this time.
Thank you, Dr. Plitzka. Next is the external evaluation update, starting with the CPW logic model that will require a vote.
Thank you. Logic model. So I believe this has been discussed at, this was discussed at the last executive committee meeting and has been discussed around all the different groups. So I think, do you want me to go through it again, Nagla, or do we just want to vote on it?
If you want to, I don't know, once we bring it up,
Okay.
if we can just
Review it.
if anybody has any
Sure.
comments and vote.
I have it if you want me to.
Drum roll.
Sometimes this doesn't follow.
Here we go.
Make it a little bit bigger.
That's clearly mud. This is an eye test.
Okay, so just as a reminder, this was the CPW logic model. And as I mentioned, we've reviewed this at the executive committee before. So take a look here. I don't believe there were any comments, but I'm happy to answer any questions. Alright.
We've spent a lot, considerable amount of time going over this model previously, so I don't think we need to go over it. The long-term outcomes are of particular interest. We need to vote on whether we adopt. Yes. So can I have a motion to adopt this model? Dr. Plitzka, second from Luann Southern. All those in favor say aye.
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 Those opposed say nay. Any abstentions? Believe the motion passed. Thank you all. Let's move on to the review of the CAP logic model. And there it is. Okay, I'm going to go see the ophthalmologist as soon as I leave this meeting.
This one we have not gone through in detail at the executive committee yet, so I'm going to go through it here. But we have presented it at the HRI meeting, and we've gotten feedback from various individuals as well. So here the goal, as you all know, is to strengthen and expand the Texas child and adolescent psychiatry workforce by increasing high quality CAP fellowship training opportunities that prepare fellows to practice in Texas and provide psychiatric care to children and adolescents. The inputs here are funding to support the fellowship positions, the participating HRIs, the CAP fellowship medical director and work group, the fact that it is an accredited child and adolescent psychiatry fellowship program at all of the different HRIs, all of the CAP fellowship program directors, coordinators, faculty and supervisors, the fellows, and all of our training sites and healthcare system partners. The activities are that the HRI CAP leads participate in leadership calls. Anissa, can you make it a little bit bigger? Yeah. Right, okay. Also to support, what's moving on its own? To support the CAP fellowship positions and program capacity at participating HRIs, to recruit and onboard CAP fellows into 2-year fellowship programs, provide the supervised training, didactics, case conferences and specialty rotations, place fellows in diverse clinical training settings, develop opportunities for shared recruitment across the HRIs, and monitor fellowship capacity, slot utilization, fellow completion, and post-fellowship employment placement. So the outputs monitor the activities. So we look at the number of participating HRIs, the number of leadership calls, number of slots, the number of slots filled, the number of fellows enrolled in the training, number of shared recruitment experiences, number of CAP fellows completing fellowship training, documentation of fellow employment placement after fellowship completion, and number of CAP fellowship graduates accepting positions in Texas, and also documenting their permanent email addresses. Then moving into the outcomes, we want to increase at the short term, increase access to CAP training opportunities by increasing the number of CAP fellowship slots, increase the proportion of slots filled across participating HRIs, increase fellows' intention to practice in Texas following fellowship completion, and increase perceived support for CAP fellowship recruitment and retention among training directors across participating HRIs. And then the intermediate outcomes are to increase the number of CAP fellowship graduates entering the Texas workforce following completion, and increase the geographic distribution of CAP trained psychiatrists across this. And then more of the long-term outcomes are obviously increasing the ratio of child and adolescent psychiatrists to the child population in Texas, decreasing that workforce that was talked about earlier, decreasing the workforce shortage, not the workforce, decreasing wait times for child and adolescent psychiatry services, strengthening statewide capacity to provide care, and then a more stable and sustainable child and adolescent psychiatry workforce pipeline. I think that is the logic model. Dr. Brenner, if anybody else has any comments, please feel free to chime in.
My only comment, Melissa, is I think you and your team have done a really wonderful job.
Thank you.
Integrating everything that's happening into the logic model.
Thank you.
Thanks.
We did receive a lot of feedback, which was really helpful.
So we're not needing to vote on this, but let's see, Dr. Raji has a comment.
Yeah, a question. So thank you. I mean, this is great work. Is the research track part of this within the scope of this logic model, or the
Dr. Plitzker.
Actually, no, the CPW is community psychiatry workforce. So that doesn't mean a research track resident could certainly have a CPW rotation and maybe conduct part of that project while they're doing their CPW rotation. But the CPW does not fund elective rotations, research rotations, things of that sort, because that wouldn't be consistent with the statute. So that is a definite subtlety there that's very important. And CPW only funds patient-facing rotations.
And Dr. Raji, I'd say that it's not represented in the logic model yet, because the logic model is really meaning to capture what's been going on in all of the CAP fellowships over the last number of years. And we think of the research track as still a pilot project.
All right, thank you.
Adam, you'll agree. The CAP fellowship, there's no such prohibition on any kind of rotation. As long as it's educationally appropriate under your jurisdiction, then it's fine. But it's the CPW that is the community psychiatry focus.
Okay, thank you for the clarification. We're going to move on now, unless there are other questions. We're going to move on to the internal evaluation update. These will require votes. So we'll start with CPW, performance measurements.
Yes, thank you. Okay, so at our last executive meeting, we brought new performance measures for CPW and CAP Fellowship. These are two programs that did not have performance measures last year, so these will be new beginning this year. And you want to move through, we'll move through pretty quickly. Just a real quick reminder that the performance measures are really our collective decision about areas that we want to focus on broadly across the HRIs. HRIs will also have access to other measures that we hope will help them understand the management of their programs and the outcomes that they're experiencing. So we'll start with CPW. The proposed measures here are primarily focused on the training experience of the resident and come from a survey that we do following rotations. Those will be those first couple ones. And we've also got a measure of participation in leadership calls, which is consistent across all of the programs. And then a measure looking at increased access to child psychiatry services for children and youth. So those were our measures. We did not get any specific feedback about these measures since the last meeting. And then do you want me to pause for vote or do CAP?
So we need to vote on these. Right. So if we could have a vote on this initial presentation by Dr. Lopez on the CPW and CAP performance measures, do you have a motion to approve?
So this would be specifically on CPW only.
Dr. Plitzker, approve a second.
Second.
Luann Southern, second. Thank you. All in favor, say aye.
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 Opposed, nay. Abstentions? I believe that passes. Thank you. Dr. Lopez, if
Yeah.
we could,
So for the CAP fellowship,
separate, sorry, Dr. Lopez, sorry, I got ahead of myself.
that's great. So CAP fellowship is pretty simple. We have one measure that's just looking at participation in leadership calls.
Okay, in that case, a motion? Dr. Plitzko, a second?
Yeah.
All those in favor say aye.
Aye.
Aye. Aye.
Those opposed, nay. Abstentions? That passes unanimously. Now we can move on to CPAN, PeriPAN, and TCHAT. Updated measures, can we vote on them in unison or individually?
Yes, sir.
Individually. Okay, Dr. Lopez, if we start with CPAN?
Yes, so while we are pulling up the CPAN and PeriPAN and TCHAT measures, same general information about performance measures versus observational measures. I will primarily highlight, most of these measures are ones that we have in the current fiscal year. Go ahead and go to the. So I really just want to highlight any differences. And my memory is from these, other than not yet having the full data to be able to use our caller satisfaction measures, we are hoping that that's going to change with some upcoming changes to the trait system. So those are sort of on hold for now, but we still want to have them approved for when we are able to put those in place. Go ahead and move to the next slide. That may be it. Okay. We've got in here the same measures kind of throughout. The one that I want to highlight is different for PeriPAN and CPAN are those two that look at outreach. So proportion of PCPs enrolled in CPAN, and then proportion of OBGYNs enrolled in PeriPAN, since those are the primary audiences for those two programs. Those are not yet in place, but we expect them to be becoming in place as that data gets defined for the next fiscal year. So those are the two new ones that I just want to highlight as we vote. So I guess we'll start with CPAN.
We'll now vote on the CPAN evaluation. Do I have a motion?
Move to approve. Second.
CPAN and PeriPAN, sorry, correction. CPAN and PeriPAN. So do I have a motion?
Move approval.
Second.
Okay. All in favor, say aye.
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 Opposed, nay. Abstentions? Well, that passes. Thank you. Now we'll move on to TCHAT. Dr. Lopez?
Yes, thank you. So for TCHAT, again, we have mostly similar measures to what we have this year. I do want to comment on timely access to care. We did get one piece of feedback on that one that I just want to provide a little clarification around. We do indicate in our documents that the benchmarks that HRIs are looking at to compare themselves to are individual to the HRIs. And a comment came in saying if the benchmarks are independent to the HRI, then why do we have one set date for 20 working days from time? And so I did just want to clarify that we are looking at the same standard for what qualifies as timely access to care across all of the HRIs, but HRI's ability to get there with all of their students may vary. So we are, just different sizes of populations, different numbers of referral that are coming in. So those will be specific to where HRIs are kind of starting from. But the 20 working days will be consistent. And then one more on the next slide that I want to highlight. The proportion of cases involving parent or guardian is a new measure that we are bringing in for this year that really focuses on parents or guardians being involved in one or more of the sessions as a part of their TCHAT participation.
And I think that's about it. That was the only comment that we got as a part of that.
So we need to vote on these TChat measures. I could have a motion. Thank you, Luann. Thank you, Stephen. We have a motion and a second. All in favor, say aye.
Aye.
Those opposed, nay. Abstentions? That passes. Thank you. And I'm turning the chair back to my colleague, Dr. Leahy. We're right here.
Okay.
Just as far.
Well, sorry again for having to step out. And so we're ready now. Am I right for the CTRN update?
No, it's YDS round.
For the Y, okay, so, okay. I thought you had said completed. Okay, so let's go to the YDSRN update. Dr. Trivedi?
Hello, can you hear me?
We can.
Wonderful. Thank you very much for the opportunity. Next slide, please. So this is our total sample. We have consented 3,194 participants, of which 2,831 have been enrolled. Currently, we have 1,435 active. We have trained 469 staff, 23 of them in this fiscal year. And our long-term follow-up is really proceeding very well. We now have 171 participants who have completed 2 years of follow-up. And we have overall completed 24,110 visits overall. You can also see number of completed visits by month baseline all the way to month 60, and by year on the right side in the blue. And so this really gives us the total number of participants. Next slide. One of the things that we have noticed, and we have included this in a lot of publications, is that already in our population, we have really very severe illness in our participants, and that is amazing. Look, if you look at like 30% of people with severe anxiety, 28% with moderate anxiety. Similarly, with depression severity also between moderate and moderately severe, moderate and severe, we get a very large proportion. So the children and adolescents that our clinicians are seeing are very severe population and early age at onset. Majority of our population, understandably, because that's the focus of our population, is 12 to 17-year-olds. But we also have about 30% who are 18 to 20 years old. Not surprisingly, 2/3 or more, actually 72% are female. And we have a fairly representative ethnic and racial distribution in our population. Next slide. We also have the behavioral activation, which is a true workforce expansion program, because these are lay interventionists who are trained by us. And that program is called Activate, which is behavioral activation for teens. And you can see the flyer on the left side. We have enrolled 115 teenagers, 65 have completed, and 10 are in progress. We have completed 7 training sessions, and the most amazing thing is these are 75 staff members trained around the state who are actually not licensed clinicians, but they are interventionists. So this is really a true workforce expansion program, and I think we are very excited about it. We have an R01 currently under review at NIMH, and hopefully if we get funded, then we'll put that on top of the YDSRN network. Next slide. We have been busy with our publications, and we actually have had a wonderful year this year. So we have 37 papers published and in press, 13 manuscripts are under review. We actually just got this last week, 3 of them requesting resubmission. So I think we are really headed towards a very good year this year. We have 2 papers in JCAP coming out, and we are finding very interesting things. Like people have questioned whether atypical depression is common in teenagers and adolescents. And we find in our sample about 22% of our teens have atypical depression, which is hypersomnia, hyperphagia, which will require different treatment. it also may have a different biology associated with it. Our paper in PLOS Mental Health was on the front page of their journal for problematic substance use and social anxiety in schools. So we are making very strong progress with the publications. And one of the things that we have really focused a lot this year is to make sure that all the nodes are taking the lead on these publications. So a lot of the publications are actually, we are rotating around all the nodes. And so in effect, all the nodes have taken lead on publications. So this is not just coming from the hub, this is going around the state. And we are engaging junior investigators as well as others who have not generally published in the past. And so we are very proud of our partnerships with our colleagues across the network. The full network is actually very active, so I'm very pleased and excited about their participation. As you can see, the publication proposals are really coming in fast and furious, and we are doing all we can to make sure we satisfy the requests from everyone. Next slide. These are the latest ones. One came out in psychological medicine, where we actually looked at trajectory of suicidal ideation and behavior across the network. And we find 3 different trajectories. So the trajectory that has the worst outcomes, we can then focus and pay more attention to it. And the second one is this latent class analysis of depressive symptoms. Really wonderful and very exciting paper that just came out in Journal of Child and Psychology and Psychiatry. All the publications are available on the website, and so people can go to this and look through all the publications. We just got a request for resubmission to JCAP, the Child Adolescent Psychiatry Journal, and we are very good and excited about that too. Where we found that the use of atypical antipsychotics is very high in our population, with unfortunately not enough evidence in randomized controlled trials. So this is creating new evidence for efficacy of these medications. Next slide. We also got a NIMH grant recently funded on social media concerns related to emotional experiences called Screens. And this NIMH grant is now currently being implemented across the network. And we have, as I mentioned, another R01 on behavioral activation that is under review, that's going to be reviewed in October. And we'll keep you all posted on that. So we have submitted 13 grants, 5 have been funded with over $5 million awarded to different research projects on the network. So that is new grants, new funding that was made possible because we have this exciting existing network across the state. And we have taken real pains over the last 2 years to ensure that all the nodes are very actively engaged, and I think that has been a pleasure for us. Next slide. I'll stop here, but ask Dr. Wakefield if she has anything else to add, my partner in this.
Sure. I can't help myself. I think, this is such a meaningful experience for me that the state of Texas funded us to try to really tell the story of what's happening with children who have depression and suicidal thinking and behaviors in Texas. And I'm often discussing with the residents when we're training and thinking about patients is that we don't have a lot of studies to guide us in the kids that we see because so many studies are so short term or they have such high exclusionary criteria. And many of the kids that we see have lots of different things going on across transdiagnostic, lots of different diagnoses, lots of different histories of trauma and family history. And so it's such a privilege to get to better understand what our children are suffering from and what is actually helping them and what may not be helping them so that we can inform future policy and future treatment for our kids. And thinking of, just the Activate program, I can't tell you how many people across my life have said, why are we just medicating kids? Why can't we do these other, get out and exercise and learn how to feed yourself? And how do you really activate your body? And could that help with depression? And so it's such a privilege to have this portion, not just for the workforce expansion, but to tell the story about how we can make a difference on a wide scale with really helping people know how to move their bodies and do healthy interventions and healthy behaviors and to improve their depression. With or without medicine when that's appropriate, but also that this does not require a clinician. It requires a trained person, but not a clinician. And what what an opportunity that is for Texas to really make a huge impact in the well-being of our communities and the future mental health of our children. I just want to make sure we also thank Dr. Linnell Goodman for her leadership, because we can't do this without her. She is a force and has lots of great ideas and amazing leadership and management over this project, and helping us answer these questions for Texas and Texas children and families. So thank you.
Thanks a lot. This Activate program is really interesting. We now have trained and certified interventionists across all the nodes, so it is not, no node is left behind.
All right, very good. The other, Dr. Raji?
Yeah, just a quick comment. And I want to thank Dr. Trivedi and Dr. Wakefield for really terrific leadership of this unique program, and Dr. Goodman. With so many participants and so many years of follow-up, it would be great to see more and more proposals for grants from across the HRIs that take advantage of this, rich, broad, and deep data set. So we can see more and more of external funding generated out of this data set. So
yes, please. If anybody has any question, or and your teams and your investigators in your departments, I think, please send them our way. We are very happy to help with the process, with submissions, with anything they need, because as Dr. Raji said, more grants on this would be exciting. And I think it is a unique infrastructure that peer reviewers like. When we got submitted grants, I think that is something they found very useful.
Any other comments? All right. Not seeing any. Thank you, Dr. Trivedi, Dr. Wakefield, again, for your strong leadership in moving this forward, taking this idea we had about 5 years ago, 6 years ago, and turning it into this really good platform. And again, it'd be nice to see it leveraged for other research projects across the consortium. With that, let's transition. Dr. Nemiroff, go to you for the CTRN.
You bet. First, let me acknowledge the wonderful work of my co-director, Dr. Wagner, and Dr. Newport, who runs operations for the network. So if I can go to the next slide, please. This is the largest cohort, I'm looking at Luann, this is the largest cohort of children and adolescents exposed to trauma that have ever been collected. And you can see we're at 4,300 plus subjects in the state of Texas. And what you're looking at are the numbers we've seen at baseline. And as you know, we're following them for 2 years. And I'll show you the retention rates, but they're really extraordinary. So this is an amazingly rich database. Next slide. The total number of visits has been more than 14,000. And you can see that we've done very well on a monthly basis. And we've actually, even though there is a bit of a summer dip, you can see that we've been, the HRIs have done wonderfully well here. These are the baseline enrollment numbers. Next slide. These are the total visits, so you can see how really busy the HRIs are, seeing, upwards of 200 to 300 subjects per month, because the 1 month, 6 month, 12 month, 24 month follow-ups. Next slide. Here are the retention rates, which is really quite good for a longitudinal study. You can see 1 month, 82%, 6 months, 63%, more than half at a year. And we're now looking at the trajectory data. Very, very exciting. Next slide. This shows you, for those who might be interested, the various sources of where these children and adolescents are being recruited from, and some of the changes that have occurred over time as the network has matured. So you can see lots of original referrals from psych outpatient clinics, and that continues. But you've also seen medical inpatient, and now more recently, referrals from the website, referrals from the family, which can occur through the website. I'll talk about that in a minute. And what's really cool about this is each of the HRIs have a unique pattern of referrals based on their own individual health systems. Next slide. You will recall that one of the major initiatives for us was to train clinicians in evidence-based care, and in particular, trauma-focused CBT. This was a wonderful initiative that was supported by this executive committee, and you can see that it's moving along. As you can see the number of subjects that are active, how many have completed, and so total of about 225 individuals have been or are currently being treated. Remember, the training is incredibly intensive. Next slide. So we've trained almost 80 therapists that are accredited in delivering trauma-focused CBT. Some have trained and they've gone into private practice, and so it has increased the corpus of trained TFCBT therapists. Next slide. We have a number of presentations at national meetings. These are just a couple of them. The International Society for Traumatic Stress is meeting in San Antonio, and here are two presentations coming out of the CTRN network. And then you see Dr. Wagner is actually chairing a symposium at the National Child Psychiatry meeting, which will be in Atlanta in October, with a number of participants from the nodes. Next slide. We've been very busy with publications. You can see here the list of peer-reviewed publications that have been published already. And on the right side, you can see the journals that we've published in with their impact factors. These really quite well-known and established journals in the field. Next slide. And all the nodes, of course, are participating in this. We have almost 10 current submissions. Dr. Wagner chairs the publication committee. Every one of them is vetted and coupled with one of our biostatisticians to work with them. This includes junior faculty at a number of institutions, but also a research track or residents as well. Next slide. These are manuscripts that were approved by the publications committee and are currently in process, which is, as you could see, quite a large number. Next slide. Well, we've been very pleased by the extramural funding. That was one of the charges of the consortium, was for us to seek funding from outside. So we've received a $4.3 million grant from the NIAAA, and 4 of the NECMAR grants are based on the database from CTRN, and that totals 1.3 million. And then we had a small grant early on from the Hogg Foundation. We are in the midst of preparing additional grants. The current grant that we have, we're intending to submit a competitive renewal. Next slide. And finally, we are launching our new website, which we're deliriously happy about. And we encourage all of you to get on it. I think I sent Dr. Lakey the link to this that will be distributed. And it's for consumers, it's for faculty, it's for parents, the general public. We're pretty excited about it. Next slide. these are thus far tracking the new website, and we're getting a lot of traffic, as you can see. So pretty excited about it. You can see the training curriculum. You can see our REDCap database and some de-identified data sets. Next slide. I think that's it. Dr. Wagner, would you like to make any comments about our network?
Sure, I'd be glad to. I think, you know, our network and also the Depression Network, you know, is quite remarkable. For me, there are a number of things that are impressive about our network are the number of children who have enrolled, then the family's willingness to enroll them in this, over 4,000, to learn about the outcomes of abuse in children, to implement a training program and increase the workforce with regard to trauma-focused treatment. And I think for me, what's really exciting is the collaboration amongst all of the investigators, and in particular, the junior investigators. Actually, during the course of it, it feels like we've been doing this. Sometimes it feels like it's new, and sometimes it feels like it's forever. But during the course of this, some of the young investigators have gotten promoted. So, and they've formed good collaborations amongst themselves. So we're not only increasing the clinical workforce, we are increasing the research workforce. So it has, you know, everything about it has been a success, and we're extraordinarily appreciative to the state for the funding.
Very good. Any other comments? I think one of those things for us to Sylvia? Okay, Dr. Muskie.
I just have a question actually for both the depression and trauma. On the referral sources of the outpatient, is there a way that you could tell how many of those are coming from the LMHAs? Do y'all have that particular data able to drill down?
Yeah, I think we do have data on the source of referrals. So if you have specific questions about that, I'd be glad to find that data and get it to you.
Thank you.
Yeah, we also have the same salary, so yeah.
Any other questions, comments? Just the one thing I was about ready to say is, especially as we approach the legislative session, making sure we can make the research understandable, especially linkages of the research to changes in policy or understanding the systems of care in Texas, I think will be very important, and look forward to ongoing conversations, especially if we try to grow this, making sure that we can show the legislature it's not just research for research's sake, but it's actually impacting policy in Texas, I think will be helpful.
Okay. If I may, Dr. Leakey, one of the things that came out of few EC meetings ago was having kind of one pagers to talk about the topics so that it's more approachable, more understandable, and we can share that with providers, policymakers, state agencies, et cetera. So we are in the process. Margaret's been working with both research networks to try to think through what that looks like and how to get that into place.
Just tell us exactly what you want concretely, and we will respond.
Absolutely, we're happy to.
Okay. Margaret, I think you're next. For the NECMR grant update.
Yeah, so our NECMR grant, NOFO, was released on July 8th. And I have led one of two informational sessions. One was last Thursday, and the upcoming one is this Wednesday. For anyone who's interested in applying for the NECMR award for the FY 28-29 cycle,
And I think that these informational sessions really are open to anyone, not just folks who may want to be principal investigators or co-investigators. I interact a lot with finance staff. I think it would be fine for those folks to join as well. Right now, the pre-application is due September 30th. With the full application invitations to follow after that. So this is all getting started and we are rolling full steam ahead. And I think that's about it. Yes, and we have two speakers. Dr. Kim is going to be speaking. They're both recipients of the 25-26 NECMR money, and then Dr. Trent is going to go second. So I will turn it over to Dr. Kim going first.
Thank you so much for awarding this funding this our study, and also thank you so much for giving us to present our preliminary result on behalf of our team. So our program is evaluating Texas Youth Empowerment Services. Oh, can you go back to previous slide? So I just wanted to also introduce some of my co-investigators. So we have two co-I, Dr. Jack Tsai and Dr. Trudy Krause as well. So Dr. Krause is co-founder of the Center for Healthcare Data. So we use the data from the Center for Healthcare Data. So I wanted to thank that as well. And we have Dr. Scott Lane from medical school, and also Dr. Pavatope. She's also here as well. So thank you for your support as well. So next slide. So I think it's most of the people here is already familiar with this program maybe. So this is for the children with the severe emotional disturbance. So those children have a mental and behavioral or emotional disorders that substantially impair their functioning in daily life. And it is estimated about 10% of children in the United States experience SED with the functional impairment at home, school, or in the community. So with this condition, children experience frequent psychiatric hospitalization and also readmission, resulting in increased healthcare utilization and healthcare expenditure. And it also places a significant burden of family and caregivers, making care challenging and sometimes leading to out-of-home placement. So the focus of caring these children is to meet their complex and multi-system need, address it, maybe not address it, adequately addressed by the residential treatment program. Next slide, please. So to address the complex need of children with SED and their family, many states use Section 1915 Medicaid home and community-based service waivers to support coordinated multi-system care. So these waivers allow state provide more flexibility to deliver intensive home and community-based services for children with SED, while also enhancing the family support and improving access to the needed services. So in Texas, we have a Youth Empowerment Services waiver, which is approved by the CMS. And this program provides a home and community-based behavioral health services for eligible children ages 3 to 18 with SED. And here is some timeline. So it was started in 2010 as a pilot program, and then it was expanded as statewide in 2015. And then it started to include also children in Department of Family and Protective Services for conservatorship as well. And then statewide implementation now is under a state STAR kids, that's MCO. So the way we identify these kids in our data set is those kids are under the specific MCO program, which is grouped as a STAR kid, and then they were grouped as a special risk group. So we were able to identify who's in this program, and then what are their previous enrollment or previous utilization before enrolled in this program. So that allow us to analyze this data set. Next slide, please. So this Yes Waiver program is not separate program. It is in addition to the state Medicaid program. So state Medicaid program, so under these programs, children and adolescents, they will receive regular Medicaid program, but their coordination of care or their rate for their risk group will be much higher than regular children and adolescents. And that allowed MCO to provide more intensive care as well. And also non-specific, non-traditional services will be provided on the fee-for-service basis. So this waiver-specific programs include adoptive aid and support, or their family support, or they have some specialized therapy like animal assistance therapy or art therapy, or some of the therapy are not traditionally supported by regular Medicaid. And this is provided administered through LMHA, LBHA within their designated service area. So next slide, please. So what we were proposing, or we proposed, and then we got the funding, and then we are conducting the study right now. So we conducted a comprehensive analysis of using Medicaid claims data, both for Yes Waiver services and Medicaid state plan services. We wanted to make sure whether these program is effective, and also whether these are more long-term outcome as well. And also we wanted to understand what children and adolescents in this program as well. So we have three aim. Aim one is we are comparing pre-yes enrollment or post-yes enrollment. We are comparing their healthcare cost, and also what additional costs for yes program, and also their outcome. Here we are primarily looking at the inpatient admission and also EDPs as well. So that's comparison time frame before and after their yes program. So we wanted to see how much this yes program helped the children be more stable or lower their acute care healthcare utilization. And aim two is, since this involved participant demographic and their clinical characteristic as well, we wanted to make sure what factors actually affecting those effectiveness or outcome. And so we were looking at the characteristic of a participant, and also their neighborhood characteristic as well. And also these their state Medicaid program is provided under MCO. So we want to looking at which MCO actually performing better, or whether there is any variation across the MCO as well, to cover the same risk group population as well. And also there could be some geographic or some LMHA or LBHA variance as well. So since this is specific provided within this region, we wanted to see whether there is any like particular factors affecting this outcome across this LMHA or LBHA regions as well. So that's aim 2. And aim 3, we wanted to make sure this YES program is much more effective compared to those kids with the similar needs but not in this program, because this is open. The children with SED, they're open wait. They are experiencing waiting period, because not all children and adolescents are available to enroll this program. So they have to wait, and then maybe like there are more children and adolescents who can be maybe benefit from this program. So we wanted to compare if there is the children who has a similar need and similar characteristic, what would be the differences between children's outcome and healthcare utilization who are in this program versus not in the program. So that's aim 3. So currently we are lapping up the aim 1 and aim 2, and we are processing to getting the access for the aim 3 for comparison group as well. Next slide, please. So here is some preliminary results. So we will identify those who are enrolled in YES program, so that the overall monthly enrollment is about, that there is some variation, is about 10 to 1,400 children and adolescents. And you can see the age group differences. Biggest the age group is 13 to 15. And to evaluate this the expenditure and an outcome, we derived the cohort. So this is some requirement to be enrolled to be eligible for this study population. So as of today, we have the data up to 2024 August. Or maybe not as of today. We maybe have a little bit more now. But when we conducted this study, and we had that until the August 2024, and we had the unique count of yes participant is 6,802, but we wanted to use this data set from 2019 to later years, because you are using this data, Medicaid data, through Texas APCD, all payer claims data. So that data is available for only 2019 or afterward. So we were looking at that time period. And also we wanted to also make sure they are enrolled in 6 months before this index period, index enrollment, or wanted to make sure they were enrolled at least in Medicaid in 6 months. So we can have the data for those time period. And we were also looking at the what's the first month of yes enrollment, but we decided to use that one as a transitional period because that period often kind of mixed it. So we were not we are comparing pre yes 6 months before the first enrollment, and then the first 6 months and from the first enrollment actually. So we are actually allowing 1 month a transition time period before the enrollment as well. So final cohort, final study population, we have the 3,473 unique children and adolescents. And here are some characteristic. As you can see, there are some differences between male and female. And then female children and adolescents, they in this program they are much older, a little older. So you can see their age group 13 to 15 or 16 to 18 is much a higher percentage in female. And we have Hispanic, it's much higher, much predominant population in here. And then next followed by the white, non-Hispanic white. And across this MCO service delivery region, we have the widespread of these some high population area. We have much larger the sample size as well. And we tried to looking at what kind of their mental and behavioral condition they have. So majority, they have ADHD, or they have also high percentage of depressive disorder. And especially for male, we have higher, especially for male, ADHD is much higher, and depressive disorder is much higher for female. And also we see that those trauma and stress related disorder is also one of the highest condition as well. Next slide, please. So when we are looking at the monthly cost among those people, that's some trend. So number one, if you see the X bar indicating what's the relative months to the yes enrollment. So you see the 6 months before and 5 months, 4 months, and 3 months prior, or first month prior, and you can see the medical cost is getting down. And also we wanted to see what's the service type to cover the cost, the cost. So we break down inpatient and ED and other you more likely have an office visit or other facility, outpatient facility, and also prescription medication as well. As you can see, ED one, we wanted to exclusively categorize it. So if your children were ED and then admitted to the inpatient, we counted them as inpatient, the cost as well. So as you can see, that's what's much, the percentage, the relative percentage here. So what we were glad to find it is those inpatient cost is much smaller after this yes enrollment. And we counted what's the hospitalization or ED visit. And since this is the count to, we wanted to, we reported per 100 per member per month. So it's the 100 people per month each month. The monthly one. So you can see the inpatient is almost 25 25 per 100 PM, but the later it's much getting down. It's have like 10, and also like ED visit also decrease. So here are some summary statistic or summary finding we reported for actual number, the dollar cost, and also utilization size. So we see substantial decrease, and we identify those yes related cost. We were looking at the mostly monthly cost is about 352. So those other services identified as a yes program. We identified 352. Can you next slide, please? So we are still working on this, so maybe not really like a clean, but what we wanted to see what kind of services they have or they use as outpatient services. So when you're looking at the pre-yes program, those we identify those using a CPT or a HCPCS code, and we counted the number of claims. So pre-yes enrollment, we were also targeted case management or personal care case on OERC, some psychotherapy or family therapy as well. And after the enrollment, the number of these the cases much higher. Like it see that the numbers that for now is a 60,000 the 60,000 number of claims. So we are looking at the targeted case management and personal care, and also we have other therapeutic activity or also support from school activity as well. Actually, that one is for the yes related one. So if you're looking at the third table, that's we identify those more likely yes under the yes services. So we see activity therapy, and we were looking at some personal care within the community or in school, and some medication administrative help as well. So that's what we find for yes related services. Next slide, please. So I wanted to emphasize what could be the challenge and limitation, since we are not actually using like a data from this LMHA or actual provider. We are using the Medicare claims data. So our analysis are limited to the Medicare claims and encounter data, and we rely on enrollment file and also services identify those CPT or HCPCS code to identify yes services as well. And we don't have a qualitative data as well. So for the future direction, we wanted to expand it to include the qualitative analysis such as focus group interview or provider survey. And we are welcome to identify or collaborate with the community provider or people from on this session as well. And we wanted to develop this subsequent project for similar Medicaid program, or maybe like a multi-state national level analysis as well. And also we wanted to focus on some subgroup, the specific subgroups, such as those who has more juvenile facility, juvenile correction involvement, or someone with a former foster care, or with a trauma care as well. What we were surprised to see a lot of services also, they have a place of service code as a juvenile or correctional of the facility. So we haven't looking into why they have these many services receiving these services in this juvenile or correctional services. But that might be something we wanted to apply for the next cycle, to looking at more those like a specific population as well. Thank you.
Thank you so much, Dr. Kim. Next, we'll hear from Dr. Erica Trent.
Oh, Dr. Wakefield.
Oh, I'm sorry. Dr. Wakefield has her hand up.
Is it okay if we just ask a question of Dr. Kim briefly?
Sure.
Thank you, Dr. Kim. That was amazing presentation, really interesting. And the answer to this question is probably we can't see that with Medicare claims data, which is totally fine. But I was also interested if, when you look at the other, because the yes waiver can cover things that are not just those direct services, is there a way that you think you could capture those things? I think that would be a really important story for the state as well. Like, what are we doing to support these kids in their home environment? I know that when I've discovered things trying to help child get a mattress or a bed or something like that, and how important that is to their mental health. And I know we probably can't get that level of data, but just thinking of, are you thinking if we understand the Medicare claims and that other category, then we can kind of say, well, the rest of it must be those other kind of social supports? Or do you think you have any ability to answer that question as well?
So what we categorize as other is we exclude those counted as inpatient setting or ED setting, and everything we covered as other. So as you can see on the second to the last page, we have those services. That's more likely for the other services. So you see those service category, those with this the middle one is that, or the third middle one, or the second table, maybe yeah, that's the specific services provided on the for these children. And we were actually able to find identify like what kind of services, as long as there is some code exists. But that's yeah, we're happy to go further or deeper identify those services as well. And who has?
Yeah, it was sort of supporting, I think, what Dr. Wakefield was saying. So it's your ability to see the non-traditional services that are provided, is that difficult, or is it just you have to base it on the Medicaid data that you have, like the equine therapy or a membership at the gym, those kind of non-traditional services? Are you able to identify those?
So what we were identify is some caregiver services at school, or some non-traditional therapies such as animal therapy, or those, as long as they have a specified HCPCS code by state. So those are separated by in the fee-for-service claim directly by the HHSC. And there are some HCPCS code which is not a regular CPT or HCPCS code. If you Google, you probably don't find that code. But we have that crosswalk from the HHSC, which they were used to pay that the services. So yeah, thank you.
Any other questions for Dr. Kim? Okay, Dr. Trent, we're going to hear from you next.
Yes, thank you. Do we have the slides up already? Should I share my own slides?
Yeah, they're coming.
Oh, there
Here
we go. Okay, awesome. All right, excellent. Thank you so much. Well, good afternoon, everybody, and thank you so much for having us here. My name is Erica Trent. I'm an assistant professor at Baylor College of Medicine in the Department of Psychiatry and Behavioral Sciences. I'm also a clinical psychologist by training, so I engage in a combination of clinical education and research with a specialization specifically in childhood anxiety disorders. So today, I'm really excited to share some preliminary findings from our ongoing project that is being supported by the NECMR initiative, where we're examining how everyday interactions between parents and kids influence childhood anxiety in real time. Next slide, please. Okay, and go ahead and click a couple times. Nearly 1/3 of our youth will have an anxiety disorder at some point in their lifetime. And if left untreated, this can impair their ability to flourish, whether it's school and social relationships or their overall family well-being. This costs our healthcare system upwards of $46 billion a year. And we have treatments that work really well, but even then, 40% of kids don't fully respond to the gold standard treatments we have for anxiety. And nearly half of them will relapse anxiety symptoms within about 4 years of completing treatment. So these findings have really spurred our work in identifying what are the mechanisms at play here, or rather, what are the levers in a kid's environment that we can pull to yield the strongest or long-lasting possible results from treatment. And what really stands out consistently is the role of parents as huge allies in supporting our children's mental health and playing a role in prevention and treatment of anxiety disorders. My work specifically focuses on parental emotion socialization, or how parents are reacting when kids express negative emotions like worry, sadness, fear, or frustration. Traditional research has relied largely on retrospective questionnaires where parents and kids are reporting on conversations that have happened days ago or weeks ago, or maybe not even a specific moment, but just reporting on their interactions in general. But this kind of methodology might miss the nuance that happens in actual real-time interactions. So that's why in this study, what we're doing is leveraging this tool called Ecological Momentary Assessment, or EMA for short. EMA is this tool in which you can gather real-time data on participants' experiences in their natural environment close to the exact moment that these salient interactions are occurring. Some researchers describe EMA in family settings as putting the family under the microscope, so we get really detailed data on this. Our hope is that by capturing these child-parent interactions as they happen, maybe we get a clearer picture of what's happening in their daily interactions, and this could inform future treatment approaches that intervene in the right way at the right moment. Okay, next slide, please. So our theoretical model behind this project poses 3 core questions, where question 1 is, how do parents' responses to kids' negative emotions influence kids' anxiety in those moments? So supportive reactions like encouraging open discussion of the negative feeling may build resilience and lower anxiety, whereas unsupportive responses like minimizing the kids' emotions or parents experiencing their own overt distress in reaction to the kids' emotions may unintentionally fuel anxiety. So that's question 1. Question 2 is looking at the why. So why is it that the way parents respond to kids' emotions may influence kids' anxiety? And we think that that might be because of what kind of emotion regulation or coping skills kids are able to learn or utilize in those moments. It may be that a unsupportive response could foster maladaptive coping, like avoidance or rumination, whereas a supportive parental response may encourage more adaptive skills, like problem solving. And then question 3 is informed by the goodness of fit theoretical framework, in which we're curious about, okay, which kids may be most susceptible to these influences? And in our study, we'll be focusing on a child's temperament as one of those risk factors that would cue us into who especially might need support in this area. All right, next slide, please. All right, so how exactly are we collecting this data? So the TESTIS model, we are currently conducting this study called the REAL study, or Research on EMA of Anxiety in Families. And the study here, the goal is to examine parent-child interactions in natural settings to eventually directly inform future care. So we're recruiting youth between ages of 8 to 17 years old with a diagnosed primary anxiety disorder as confirmed by our research team, and 1 primary caregiver who participates in the study with them. Following a baseline evaluation, families complete a 15-day-long EMA protocol, during which both child and parent will receive 3 brief smartphone prompts each day, morning, afternoon, evening, in which these prompts ask, number 1, about what is a child's current state of anxiety in that moment on a 1 to 10 scale, is capturing that moment, and whether in the recent hour or 2, has there been a emotionally salient interaction between parent and child? That is, did the child talk about something that was worrying them or bothering them with the parent? Did the parent and child have some kind of a negative interaction, like an argument, for example? Essentially capturing any moments where there was an emotionally salient interaction for which we want to know what was the parent's response to the kid's emotions then, and how did the kiddo cope with that situation? Next slide, please. Okay, so far our sample has consisted of 40 dyads of youth and parents, where youth have met confirmed criteria for an anxiety disorder diagnosis. And the most represented disorders have been social anxiety disorder, generalized anxiety disorder, and specific phobia. Our average average age for kiddos has been 13 years old, with about a half-half distribution between the 8 to 12 range and the 13 to 17 range. 67% female, parents on average 44 years old, and to this day, 100% female. Next, or click please. And engagement in these EMA study has been really, really great. So parents have demonstrated a 85% compliance rate with each of the EMA surveys, which has yielded to date a total of over 1,400 EMA check-in data points responded by parents. Of these, 404 of those data points involve reports on an emotionally salient interaction between parent and child. Next, please. For kids, kids have achieved a 73% compliance rate of all these EMA prompts, generating over 1,200 check-in EMA data points, with 259 of those reporting an emotionally salient event. Click once, please. So even though our analyses that we're presenting here are focused on that dark purple boxes where some salient event did happen, even the pink boxes where they are not reporting a salient event, but they're still responding to other questions such as social interactions that day, any negative things that have happened that day, how did they cope with that? So this still provides a rich data set that could be used for future research. Next, please. All right, next, please. So for our first question as to how are parents responding to their kids' negative emotions across these many, many moments in time during their participation. So listed here are common parent responses to kids' negative emotions as identified through the literature, and a frequency chart here of the parents in our study. How often are they reporting using each of these things? So two cool things come up here. One is that parents on the whole are very frequently engaging in supportive strategies that are known to be effective, such as focusing on their child when they're in distress, helping them deal with the issue, comforting them. And parents are not engaging frequently in strategies that are known to be not very supportive or helpful, such as letting them know I did not approve of them feeling that way, or did not pay attention to them, or got upset myself. The other cool finding here is that because we have child and parent report data, click please, we're able to also gather kids' perspectives on how their parents responded to them when they were having negative, these emotionally salient interactions. And kids, for the most part, are also showing strong informant agreement. Kids are also noticing parents engaging in these supportive behaviors when the kiddo is in need. Next slide, please. So in terms of preliminary findings so far regarding question 1, which is how are these parenting responses influencing kids' anxiety? We're using multi-level models, which provides us two important pieces of data. One is the between person effect, or rather, how is one dyad's average comparing to other dyad's average showing up in their interactions? And then the other one is within person effect. So looking within one dyad, are deviations from their usual selves associated with more or less anxiety? And what we find here in the left graph is that across that 15-day period, parents who are reporting on average more use of supportive strategies also have kiddos who are on average reporting higher anxiety. And we think that this isn't necessarily a causal relationship going on here, but rather maybe that when you take a step back, those kiddos with more anxiety may by nature having to be pulling more supportive strategies from parents, precisely because they experience more chronic higher baseline anxiety. Whereas on the right side, what this is finding is that when you look at a particular interaction and then seeing how is that deviating from that parent and child's norm, on interactions where parents are reporting more than usual unsupportive strategy use, kids are reporting more than usual higher anxiety. So next slide, please. I'll very quickly wrap up. Click a couple times. Sorry. So just to sum up, it's important to look at the broad picture versus these moment-to-moment changes. And moving forward in our next analyses, we'll be looking at the role of child coping and temperament in these associations. And this could inform just-in-time parent coaching apps in the future that provide parents just the right support and just the right amount at just the right moment. Next slide, please. Want to give a thank you to all of these people. And also we are still recruiting participants. So if you are leading a site that serves these types of youth with anxiety disorders, please feel free to reach out and we'd be very happy to connect. Thank you very much.
Thank you so much, Dr. Tran. Any questions for Dr. Tran?
I don't know if we have time for questions, but I do want to thank you, both Dr. Kim and Dr. Trent. I think these are good examples of the NACMR grants and the application to what we're trying to do to improve mental health services for kids in Texas. So thank you both. And again, congratulations on being funded, and I look forward to hearing more. Thank you. Why don't we have a limited amount of time, but there's a couple legislative updates, and a budget update, and then we need to have this vote, but we can move pretty quick. So Nagla, you want to give the legislative bill update?
Sure, I'm going to go through it really quick. So we basically on HB 18, we've been implementing CPAN, PeriPAN since May, and there's a still continuous growth in enrollment. And on the clinic side, we're seeing an increase and uptick in the number of clinics. On the hospital side, we're seeing hospitals starting to engage as far as enrolling and a few services, but we knew that it's going to take some time. On the TChat end, starting September 1, the TChat is going to be implemented in the majority of the HRIs, with couple of HRIs that are just going to join during the pilot stage to learn about the experiences. After the 6-month pilot, we're going to go statewide, and that is in March of 2027, and implementing kind of lessons learned during that pilot stage. HB 6 resources that are used in TChat and CPAN, PeriPAN are placed quarterly on the consortium webpage and updated on a regular basis. There's also a couple of reports that we're currently working on that have been requested by the legislature. On third-party reimbursement, the data has all been collected on that. There'll be another meeting with stakeholders to talk about what are the findings and conclusions, and then the report will be drafted and finalized and provided back to the legislature. Thank you.
Very good. Alex, you want to give the budget update?
Yes, thank you, Dr. Lakey. Hi, everybody. We continue to move through not only our current fiscal year and our current biennium, but into prepping for next legislative session. Again, appreciate you all participating in your budget meetings and providing excellent feedback. So a couple of updates. We have been asked to submit a formal legislative appropriations request, which is kind of a formal budget to the LBB. We have always submitted our budgets, but this is, like I said, more of a formal request. And so I will be working on that along with the team and with the support here at UT System to get that submitted in the next few weeks. So please keep an eye out if I reach out to you. I'm hoping not to, but you never know. Please give me some quick turnaround if I'm asking for it. But we do plan to move forward with the requests as received in the latest submissions that you submitted. And so we will, like I said, move forward with that and be working through that process here in the next few months and probably into the legislative session. As part of that, there is some statewide guidance about requests for reductions. So I will be sending you an exercise today to request reductions at the 3% mark and the 10% mark. And I will also be hosting office hours in the next few weeks for any questions. If you have anything you want to work through live, please join me at those office hours. They will be listed in the email. Anything else, Dr. Pliska? To the 2829 request.
The main question, the 27 budget, the fiscal 27, it starts September 1. Are we supposed to work on the budgets that we discussed, or are we looking at any changes in that at
So
this point?
it's unlikely we'll be having changes in the FY27 budget. I do want to seek some additional clarification from Dr. Lakey and Nagla about what FY27 will look like. I'm working with THECB right now to truly understand how much UB was returned and how much of that is available to move forward into FY27. I don't think we're seeing a reduction, but I am working through that right now.
So if I may add just a couple things, this restructuring of the budget that Alex talked about towards that we're at LAR, it's actually a pretty big deal. In some ways, we have, so far the governance has been basically in a rider to the Higher Education Coordinating Board. It basically breaks out the consortium so that it's almost like how a state agency's budget is done. It's still part of the Higher Education Coordinating Board. That makes it in many ways a lot more transparent, easier to work with the legislature. That's how they understand things, instead of over the last several years of us working with them kind of behind the scenes to be able to get the budget issues addressed. And so I think this will be a good step. And the 3%, as we are getting GR funds, almost like a state agency now, those rules where they tell everybody, every agency to reduce your budget by 3%. We're not immune to that. And so that's part of the direction. And then we do work in the legislative session to try to get the funds built back up to the level that we need. With that, Lainey, let me go to you.
Dr. Leakey?
Yep.
Just a quick question.
Mhm.
So with the 3%, so that means you're going to be asking that, we as a group would be asking for 2 exceptional items to restore the 3% to our base funding, and then you're going to ask for the pilot funding. So it'd be 2 exceptional items you're going to be submitting.
We are working through the structure. It'll be more than 2, and because there's a variety of things related to ARPA, that ARPA money going away and now having to backfill with dollars, so that it's very clear. And we've been working through the structure of how do we want to approach that. So it'll probably be about 5, 6 exceptional items as we try to be very clear related to the transition from ARPA to GR. Yeah. Lainey?
Sure thing. So I just wanted to provide a quick update on our contract with the Center for Health Communications. Melanie Susswine, who's worked with us for nearly 5 years, is moving away from her position with the CHC. And Lara O'Toole, who has also been with us for nearly 5 years, will be taking her place. So we're very excited to have the continuity and to have a dedicated partner who understands all the work we've been doing, but just a transition that I wanted everyone to be aware of. Melanie's presented here before, and so it'll now be Lara. And also out of the CHC, they've been working diligently on our updated website. We hope that that will go live in September. And so hopefully in our October meeting, they'll be able to kind of do a walkthrough for us. They've been working diligently with our team, but also with a number of folks at the HRIs and also members of this committee, just to find your pain points in our current website and then figure out what we can do to make everyone's dreams and hopes for what the new one will look like come to fruition. I think we're nearing a really final place, which is super exciting. They're going to start doing some user testing soon. So yeah, hope to have an update on that soon.
All right. Very good. The last item of business that I have, when we were talking about the collaborative managed care, the vote for the 2027, we had to jump over because I needed to be out of the room. Claire, you want to give the brief overview of that?
Yes. So really quick to kind of reframe us. So everything that we talked about before Dr. Lakey left the room, that is going to be, this is just a program proposal. We're not voting on any of that today. What we are going to ask is that in efforts to help us prepare for what you all will eventually, hopefully, vote on for this proposal, is there are some preparatory activities that we will need to get started sooner rather than later, and would love to get those going now so that we have as much lead time as possible when we do transition to the new program redesign. So we will get y'all's formal feedback. I will send out details about timelines and all those kinds of things for your formal review of everything that was previously presented. But then for the FY27 stuff, we're hoping that the ARPA funded pilot, we're anticipating the next timelines, it would conclude in August of 2027, and the new incubator program would launch in September. And then we, at the same time, we are presenting it this way just primarily to avoid prematurely launching a new program structure in FY27 before the legislature has had an opportunity to review that the executive committee agrees on the strategic direction and those kinds of things. So next slide, the approval requested for today is the transition activities on this slide. They're designed to prepare participating HRIs and UT system for the proposed future state structure, which will be, to be determined in October or later if needed. So first, we need to responsibly close out the ARPA funded pilot. Current clinic support is funded through FY27, and we would need to begin planning for an orderly conclusion of those activities while documenting lessons learned from that pilot experience. And so with that, one thing to note for our HRI leads who have previously reviewed, this would be a pretty solid end for the currently participating clinics. But with the proposal, we are allowing clinics within the same health system that may have already previously participated to join in. So efforts that y'all have taken to work and establish existing partnerships and relationships with various health systems, we are no longer excluding at the health system level. It will be working at the clinic level moving forward. And second, if the executive committee ultimately approves the redesign program, participating HRIs will need to identify and assess those prospective clinic partners. And part of our proposal includes greater emphasis on readiness, viability, and sustainability, which means some of those assessments would need to begin well before the FY28 implementation so that HRIs have enough lead time for the partnership establishment. And third, a number of recommendations intentionally require collaborative development. So rather than prescribing every operational detail in advance, the proposal calls for a collaborative care work group consisting of HRIs, stakeholders, and relevant subject matter experts to help us operationalize the approved recommendations. So examples of that would include development of the funding framework, implementation standards, evaluation measures, and other operational details identified in that proposal. And collectively, these activities position the program for a successful launch should the executive committee ultimately approve the redesign recommendations. So we're requesting approval of these specific activities and only these activities because, again, this work needs to begin during FY27 and we want to be prepared as possible for implementation in FY28. And waiting until October would significantly compress the planning timeline and reduce the amount of collaboration available to participating HRIs and stakeholders. And then approval of these activities does not commit the executive committee to approving the program recommendations. It just authorizes the planning, stakeholder engagement, and developmental work needed to get this work moving.
Okay. So, I just want to make sure, because the nature of collaborative care being so different than some of our other initiatives, that the work group has, that the work group has ample physician membership. I don't know if it needs to be modified. You'll take that under consideration, but
that's the planning forward versus this vote for 27.
And even the current leadership has, and Claire can, sorry, the current leadership from the work group, at least that participated, there's no request to remove anybody, but HRIs can bring the clinician, the coordinator, everybody, and we've seen participation across all those.
But the vote for right now is that right there, to close out the pilot, get ready for the next, and then all that other transition work groups that will take place. But they need to be careful of not starting any new clinics or anything else as we close out and get ready for the transition. Okay. Dr. Keller?
Yeah, this is great. It makes a lot of sense. And Charlie, I'm assuming that like, the big thing that'll need to be done in the work group going forward is more putting in the kind of leadership structure we have for like Parapan. I mean, I think that's the thing that, we're certainly going to want to advocate for at the Institute, but I agree, David, we can do it through the process discussed earlier. I guess one question is, makes sense on the news sites. There is going to be quite a bit of work though, if you want to have potential sites assessed. So are you going to allow, the HRIs with existing budgets and their contractors to use existing funds to help do some of the prep? Because I mean, that's quite a bit of work to assess readiness. Readiness assessment actually is really, I think, almost like the first phase of implementation. So I assume those kinds of funds, as long as they fall within the parameters of the budget as approved, for example, like the actual staff that were approved, the actual other folks, that those can be used.
I am, yeah, go ahead. Nanda.
Yeah, so each HRI already has, their budgets outlined by category. So within those budgets, it would be utilizing that in order to do that work. And so, again, all the criteria that Claire talked about at the beginning is really more for the infrastructure moving forward with 28, 29 mostly. But yes, so if the HRI has the bank within their budget and their partnerships, then they could do that.
But not to bring on new clinics right now. Again, as you can prepare, we're going to be very dependent upon the legislature putting the funds in to be able to then implement. And Dr. Keller, do you have another question?
Yeah, well, just to clarify, but I think that's an important nuance what you added, David. That starting up a new site, no, everybody agrees we won't do that. But there will be activities with potential new sites that will happen this year that will potentially be reimbursable in order to prepare. That's the clarification, yes?
Yeah, that is correct. Not new sites. We can't obligate the next legislature, right? We can prepare and be ready. It's going to be dependent upon the legislature putting dollars in for us to be able then to stand those up in the future. Yeah, and they're using the budget that they have right now. Okay. Any other comments? All right. Again, all we're voting on are those three items that were on the other slide of closing out, preparing for the next cohort, and then establishing that the work group. Any other conversation? Do I have a motion?
So moved.
So moved. Do I have a second? I have a second from Dr. Pliska. Any further conversation? Hearing none, all in favor signify by saying aye.
Aye.
Opposed, nay. Did anyone abstain? Let the record show we got unanimous approval. With that, I think we're done. I'm sorry that we're a little bit over. Appreciate all the work, and thank you, Dr. Nemiroff, for covering me while I had to step out.
My pleasure.
With that, we're adjourned. Thank you.
Thank you all.